Good evening, everyone. Let's wait for 2 to 3 minutes, and then we will start. Yeah, just let's give two few more minutes for people to join. Just 2 or 3 minutes, we'll start. Fine, let's start. Yeah. So, good evening, everyone. I am Manikandan Katharvale. I'm one of the consultant surgeons in the London. I work at the Royal Free and the Whittington as a consultant HPB transplant surgeon. I'm also the course director for the PrepMedico FRCS general surgery courses. I would like to take this opportunity to invite all of you to this 9th FRCS course Taster Viva sessions. So we have two Taster Viva sessions. One is today, and the next one would be next Saturday. So today I'm covering. Next Saturday we have Mr. Mina Gergesi, is a consultant breast surgeon, who will be doing the session for the next week. So we have been doing this Taster Viva session. We call it as a Taster session mainly because it's just an essence of understanding how these Viva sessions would happen. And before the commencement, so we have been running the FRCS courses for the last 4 years, and we are about to start our 9th edition of our 3 months FRCS course, which is about to begin in this month end. And before every 3 months course, we run 2 or 3 Taster Viva sessions for 3 purposes. One is for our own course registered participants to come and have an extra 2 weeks of understanding and participation in the Viva sessions. The second aim of this session is for candidates who are thinking to how to start their preparation, if at all, if they're giving the exams in the next 3 to 6 months. It would be an ideal opportunity for you to just to have an understanding of where you are, what you would be needing in your preparation, and how we could be of any help for you. So that's the whole purpose of this Taster Viva sessions. Yeah. So let me share my screen. So this session will be I have planned for 2 hours. I have some introductory talk, and then we have scenarios to discuss where I need volunteers. I think most of the candidates here have registered for the course. I think if you are please be prepared to volunteer for participating. And again, the purpose and the whole aim of this session is to understand the Viva techniques. I am not here to test your knowledge on whatever questions I'm going to ask. It's to understand the essential Viva techniques or what is expected from you in the assessment of this exam. That's the whole exercise which we are planning to do. Okay, let me share my screen. Picture. Right. So you can put your questions if you have any queries on the chat box, or at the end we have 15-20 minutes to have a chat on any kind of questions you have. Okay, right. So the session agenda today would be just a very quick 15-20 minutes overview about what is the Section 2 exams. Most of you most likely would have just finished your Section 1 exams, or you would have finished your Section 1 exams maybe 3 months back, and who are preparing, aiming to write your May exams or September exams here. Few of you would be, yes, Adil, the session is being recorded, yeah? Few of you would have given this exam before and wouldn't have succeeded, probably. So first, so I'm not going to go in depth about it, but we will be discussing about what we are actually looking for in this part of your FRCS exams. And then we will discuss 4 or 5 very essential Viva techniques, which is mandatory for you all to prepare yourself before you go for the exams. And how we will be learning this Viva techniques is by doing some scenarios. So I will be asking you scenarios, you will be answering, and then I would tell what, as an examiner, we would expect from you as a candidate. Okay, and of course, last 10 minutes, I would give an overview about the 9th FRCS course, which is going to commence in the end of this month. And if you have any questions around the course, you would be much welcome to ask me, and I would be happy to clear away your doubts. Right. So let us start quickly about what is this FRCS Section 2 exam. So you all might know here, most of you, FRCS is the exit exam for all the surgeons in the UK. So, and the standard of the examination in entirety is to assess whether you are a fit candidate to become a consultant or not. That's the whole purpose of this exam. The Section 1 exam, which you had given already, is purely a screening test, in my view. So Section 1 exam is a screening test for an consultant interview, is how I would see. So the Section 1 exam is mainly to screen candidates to come to the Section 2, which is an interview process to become a consultant in the NHS system. This is how I see. Section 1 is purely knowledge. Okay, it is just to test your knowledge to see whether you have the basic knowledge required to enter the Section 2 exam. Now, what is Section 2 exam? So Section 2 exam is not an exam which is going to test your knowledge alone, but it is something to test you as a person to see whether you are a fit person to become a consultant or not. That's the whole purpose or whole aim of this exam. Now, in Section 2 exams, each candidate will be facing 6 Vivas. Okay, and these Vivas are classified into 2 components. One is the clinical examination component, and other one is just a Viva component, we call it as. So clinical examination component is a station or a scenarios where you will be judged on how you assimilate your clinical examination knowledge, clinical findings, put together, come to a differential diagnosis, evaluate, confirm the diagnosis, and manage. So this is the purpose of the clinical examination component of the Section 2 exams. Now, the clinical examination stations, you will have 2. Each candidate will have 2. One is general surgery, and other one is your specialty surgery. And each clinical examination scenario will happen for 40 minutes. So and within this 40 minutes, you will be discussing one long scenario, which will be for 20 minutes, and then two short scenarios, 10 minutes each. The same thing you will be having in your specialty surgery also. And it is very, very essential for every one of you to know which session or which scenario you're sitting, because your answering, your approach should be different for clinical examination station compared to the Viva, which I'll be talking to you later. Because here, the whole purpose and the aim is how you communicate, how you get the history, how you put up the differentials, how you logistically think about the investigations needed, how you put together and discuss. Okay, and each of these scenarios, so throughout your exam, as I told, in the 6 Vivas, each Vivas, there will be 2 examiners will be sitting. At any point of time, one examiner will be questioning you and the other examiner will be marking you. The second component of the exam is the Viva examination or the oral examination, where each Viva is for 30 minutes. The clinical examination is for 40 minutes. This is for 30 minutes. Okay. And here you have 4 components. One Viva is on emergency surgery, trauma, and critical care. The second one is general surgery principles and clinical practice. The third one is your special interest surgery clinical practice. And the last one is basic sciences in your specialty and an academic paper interpretation. So this is the Viva component of the exam. Here, each session, so each Viva is 30 minutes, and within each Viva, you have 6 scenarios. If you take emergency trauma critical care, within the 30 minutes, you will be having 6 short cases. So each scenario is just 5 minutes, and it will be running through over a period of half an hour. Again, here 2 examiners will be sitting there. First 3 will be asked by one examiner, and the second 3 scenarios will be questioned by the other examiner. The aim of this Viva examination is predominantly to test your logical thinking, your higher order thinking, how you make decisions under stress, how you communicate, how you document. These are the things. So here the importance is you are not wasting much time telling that I want to take this history, that history, I want to examine this. Yes, you need to tell for the completion's sake, but you are not dwelling a long time on that. So here you will have just 5 minutes to answer your questions and go to the discussion. In general surgery, you will have 6 scenarios on general surgery. In special interest surgery, again, you have 6 short cases within your specialty. And in basic principles, you have 3 scenarios which will lead to a discussion on basic science within your specialty. And then you have 15 minutes where a paper will be given from any specialty, which you will be having half an hour for going through the paper, taking notes, and you would come, present the paper, and critically appraise the strengths and weakness of the paper, and a lot of statistical discussions on the merits and demerits of the paper. So this is something, a very gross overview of Section 2 exam. So anyone who starts preparing for the exam, this is minimum you should know. Okay, so the key for preparation for Section 2 exams is you need to understand the exam first. The most common reason for failing the Section 2 exam is not understanding this exam, not understanding what are the scenarios, not understanding what are they looking for. Okay, and if you see the whole distribution of the Vivas, close to 50% of questions will be from your specialty. Again, that's a very deep understanding which you need to know, because majority of the time, you might think that it's a general surgery exam and you will be wasting time in so many things and not concentrating on your specialty, assuming that you are very strong in your specialty. However, there are lots and lots of unfamiliar territories which will be touched in this exam, even within your specialty. So you need to be a master in your specialty. So 50% of the questions, you should be confident enough that you will be facing it. And the rest all, again, you have to prioritize which specialty you need to focus, which specialty you can keep last. So that's some understanding which you need. Now, what is expected in this exam? Okay, as I told before, we want you to behave, think, answer, react like a consultant, not as a registrar, not as a fellow. and not as a very senior consultant also. We don't want you to take decisions which should be taken by a professorial level consultant. We want you to be a day one consultant. How do you behave? Again, as I told before, knowledge is very essential, but that's going to help only 50%. Of course, knowledge is the basement. Once you have the knowledge, you need to initially build on your knowledge, and on the top of your knowledge, you need to add on 50% more skills, which is essential for this exam. So the entire exam will happen like it will be a discussion. The two examiners sitting on the other side are two consultants, and you are the third consultant, and you are discussing on a scenario. This is how the examination will go. Okay, and what they are looking for here is to see how mature and confident you behave on discussing any kind of scenarios. This is what they look into. Okay, yes, there are certain examiners who would behave in a very rude way, and they might treat this as any other exam where they will ask you questions, and if you don't answer, they can criticize. That's there because every examiner is different. However, majority of the examiner, the discussions will be something like a discussion within a colleague consultant. Most of the time you will be treated with respect, exactly mimicking like speaking to a colleague consultant. It is a two-way conversation rather than the examiners just questioning you and you answering. Again, unlike the MRCS exams, Part B exams, where the examiners are given a key. Okay, these are the 10 questions which you need to ask for all the candidates. Here, there is no key given. The only thing given is a theme. Okay, so if I am the examiner, I would be offered, okay, so this is a discussion on, say, post-liver transplant patient coming now with the trauma and found to have a splenic injury. This is the theme. And I will make a scenario on this, and my questions will be leading from whatever you say. If you say that I want to do a CT scan, okay, I will tell, okay, what kind of a CT scan? Then if you say contrast, okay, fine. What are the types of contrast, I would ask. Then you will tell ionic and non-ionic. Okay, fine. So what are the MRI contrast? Then I can go into, so depending upon whatever you answer, that's where the next question comes. So this is again very, very essential. You need to understand on what you need to talk in the exam and what you should not talk in the exam. If you talk something very, very rare of the rare possibilities, or if you tell something which, if at all questioned back to you, if you cannot continue, you should not utter those words. So this is how the questions are framed in the Section 2 exam based on what you tell. Okay, and the entire assessment is based on how you think, how you process, how you react to a scenario, rather than telling whatever is given in the textbook what is the right answer. Okay, and most of the scenarios will not have a single right answer. Most of the scenarios will have 4 or 5 different possibilities, and they would see how do you choose which option you would opt for based on your experience. You cannot be telling that, okay, these are all the possible options, I think the best option is this, and the examiner would ask you, okay, fine, how many times you have done this? If you say 0, that would be considered as a serious harm. Okay, so in this exam, it's like a UK driving test. Okay, so you are allowed to do, you are not looked into what correct things you do, but what we look is what wrong things you do in the exam, or what wrong things you make decisions for the patient. Any serious harm to a patient is marked straight away fail, irrespective of however correct you answered the rest of the scenario. So the key to this exam success is behaving very, very safe. Yeah, that's very, very important. So that's why, when there are multiple options, you would say, I would do this because this is what I know. Okay, or this is what my unit practices, or I know these are all the options. However, I am not the expert for this. I would call my friend. Okay, so this is how you answer, and you need to imagine exactly like this patient is in front of you in your hospital, and you are the only person who need to react to this, and you need to exactly answer what you would do, rather than what you heard in a conference, what you learned in a book, and things like that. That's very, very important. And you need to know that the examiners here are very, very smart. They very well know what you are telling. Yeah, and in the clinical examination station, when I told the 40-minute station, both in general surgery and in the specialty surgery, for the long cases, you will have real patients. Yeah. So to the real patient, you would need to get history from them. So you are also assessed for how you introduce yourself, how you talk, how you get the history. So 3 to 4 minutes, you get the history, compile them into differential diagnosis, and you answer. And any scenario, the first question is usually very easy, and then the question will build up based on what you answer, and of course it will build up based on the difficulty also. Okay, they will make the questions, the upcoming questions will be more and more difficult. Okay, and so any scenario when it starts, the first 1 or 2 questions, 100%, every one of you, even now, you will know what is the answer for that. So you should utilize those opportunities to give the best impression to the examiner, stating that you had seen similar patients in your 10 years of surgical training, you had handled these patients, and you know what you are thinking and what you're telling. So you need to utilize the first 2 questions to express this. This is called, we call it as a higher order thinking, which is something very essentially looked into in this exam. The higher order thinking is something where, even though you are a surgeon, say when you're called to see a patient, a right iliac fossa pain, all of us straight away think that appendicitis. However, you need to tell that, okay, right iliac fossa pain, I'm aware that the common cause is acute appendicitis. However, things which are running in my mind are A, B, C, D, E. The medical causes are this, surgical causes are this. Okay, so this is how you answer every scenario you start. When a scenario is given, you need to tell, oh, I am concerned about the situation. I am extremely worried about this patient. My thought process are, this patient could suffer from medical possibilities are this, surgical possibilities are this. So this is how you start answering any viva before you proceed. Okay, again, in the exam, people mistake this exam that it is a knowledge-based exam. And whenever a question is asked, they assume that the rarest of the diagnosis is being questioned, and they get trapped by themselves. For example, say patient with colonic obstruction. I have seen candidates straight away telling, oh, it could be an internal hernia, or they would say, no, it could be, say, a cecal volvulus, when they don't even utter a colonic cancer as a top differential diagnosis or something else. So again, common things are common. Whatever you see commonly in your clinical practice is exactly what is questioned here, but with twists and turns. For example, you will be getting a patient, say, presenting with DVT. Okay, uncomplicated deep vein thrombosis. How do you manage? You might straight away think, oh, it's a very simple scenario. I just need to start the patient on low molecular weight heparin, do a Doppler, procoagulant workup, follow up with hematology clinic. Then there will be a twist. Oh, this is a stage 3 CKD. What do you want to do? Then questions will go into, okay, what's a renal clearance for heparin? What's a renal clearance for low molecular heparin? Which novel anticoagulants you can use for this one? How do you follow up these patients? How do you test the activity of different? So this is how, no scenario would be very straightforward. You might get a strangulated inguinal hernia, but they will give a very frail patient. Oh, it's an 86 years old, has a stent in place, anticoagulants. He also has stage 3 CKD. He had a previous laparotomy and has learning disability. So you are not here to tell, okay, this is a right inguinal hernia and he needs an operation, but you need to assess the whole patient, starting from whether the patient is fit for surgery, what are you going to do for his heart, what are you going to do for his blood thinners, etc. Okay, so this is how all the scenarios would be. And again, any answer you state in this viva, okay, your score will be going up if you tag your answers with an evidence. For example, if you have a trauma scenario, you would tell that, okay, everyone knows that I will assess the patient based on A, B, C, D, E. Okay, if you tell me that, oh, I would like to see this patient based on A, B, C, D, E, I will give you 6 marks. So the marks for each response in the FRCS exam is between 4 to 8. 4 and 5 is fail, 6 is just pass, 7 is good, 8 is excellent. Okay, so if you say that I will assess the patient based on A, B, C, D, E, I will give you only 6. You will tell that I follow the ATLS principles, and based on the ATLS principles, I would assess based on A, B, C, D, E. You get 7 marks. Okay, exactly the same. You are going to see the ward, a sick patient in the ward. You will tell that I would like to go and assess the patient based on the CRISP protocol, ABCDE. That gives 7 marks. If you just say I will assess based on ABCDE, it's just 6 marks. Same thing, patient with fever. Okay, this patient is febrile. I'm going to initiate sepsis 6 protocol. You straight away get 7. If you just tell that I will do blood culture, antibiotics, it's exactly is what is given in sepsis 6 protocol. However, we need that catchphrase. So those are the things which is expected. However, when it comes to your specialty, many candidates mistake that they need to know all the high-end trials, this and that. I would say that the trials, the questions on all the trials in your specialty, that will be a question to test to see if they need to give, if you're fantastically doing a scenario, as a last question before they decide whether we need to give a full mark to you, they will ask some trials and stuff. And I would not waste much time in knowing all the trials. Of course, you need to know all the landmark trials. However, you don't need to dwell into knowing what does this tell, that tell, what does this trial say. You don't need to know. Once you master your basic essentials, then probably you can go and look into the trials. Again, every question here, this is another important key, is you might think within your mind when you close your eyes, if I ask you a question, you will be able to answer within your mind, okay, this is the answer. However, when you put it out in your words, when you verbalize your thought process, most of us would struggle. I know that few of us are gifted that you can produce whatever, but majority of us would struggle. And what we need is, as I told, in this 5 minutes, we would ask you 10 to 12 questions. And we want to assess you within that 5 minutes based on the 12 questions, your entire knowledge, and decide whether you are signed off for that particular scenario or not. For that, what is essential is structured responses. Every question I ask, you need to give a structured response, which should not only tell your higher order thinking, it should also express how good you speak, how well you communicate, and how good is your attitude. So all these things will be assessed when you answer. And in the exam, I would quote, if you're a well-prepared candidate, okay, 10% of the questions you won't know the answer. If you are moderately prepared, I would say 30% of the scenarios you won't know, okay? So you should be, brave enough to say that I don't know, I want to move to the next question. So that is completely expected. Again, that is a real life scenario. Even after like 20, 30 years of experience, when you end up in a scenario where you don't know, you don't know, when that's exactly a real life scenario. You would tell that I have never come across such a scenario, I would need help. Okay. Or if it is something like a hardcore theoretical question and you don't know the answer, you can tell I don't know. Okay. And of course, as I told, people here are very, very smart. When you start practicing for this exam and start preparing for this exam, you will understand that many times what we do is we tell some answer, and next time when I question you back, oh, are you right in telling this? You will try to substantiate the wrong answer, which you know it's wrong. However, you would try to substantiate. Okay. So again, those things are easily picked up by the examiners, and you should not do this in the exam, and that will definitely put you down in the exam. And as I told, most of the examiners, even if you know them before, even how good they are, on the day of exam, they intentionally irritate you. Okay, I would not use the word irritate you. They might intentionally make you feel very stressed. Again, because one of the essential component in marking in this is how you think in a stressful situation. So they create a stressful situation, not just with the scenario, but they won't accept whatever answer you say. Okay, and they will give an impression that they are very unhappy with whatever you answer, and you continue to make decisions. Okay, so this is something which is intentionally done in the exams, and you should be prepared enough to expect the same from the exam and handle it appropriately. So this is the level of knowledge. So this is, although a general surgery exam with your specialty interest, you can get questions from all these topics. This is taken from the your syllabus itself, from the Royal College website. You can get questions from anything, colorectal transplant, breast, and the level of knowledge required is in your specialty. Okay, this is So in your special interest, you should have an ST8 level knowledge. In your general surgery, emergency surgery, again, ST8 level knowledge. So general surgery, critical care, specialty, you should have a consultant level knowledge. In other areas, colorectal, upper GI, HPB, you should have ST6, and all other areas you have ST4. Although this is the syllabus given, the questions are not in this level. You need to understand that the exams are becoming more and more I would say very high standard, or more and more difficult nowadays. So what we generally say is, you should have ST8 consultant level knowledge in your specialty, upper GI critical care, general surgery and critical care, upper GI, colorectal, irrespective of whatever specialty you are. Say, even if you're a transplant trainee, you need an ST7 knowledge, which is close to a consultant, and all other specialty, at least an ST6 plus knowledge you need. Okay, this is the level of knowledge you need to know. And this is where the problem comes. Whether you are a trainee in the UK system or whether you are a non-trainee here, unfortunately, most of our last 3 years in a trainee, you will be in your specialty. And if you are a non-trainee, you would have been only in a particular specialty, and you don't know what is happening in the transplant field in the UK, breast surgery, endocrine and vascular. And this is something where you need to identify this in the beginning of your preparation. You need to know where you stand in these areas, and you need to put appropriate effort understanding and knowing all these things. Okay, this is not like section 1 exams where you study some theory, you do some questions, go back, and you do it. This is completely different, where every answer you say, you have to verbalize your reasoning for your answer. Okay. And this is again a very important document every one of you should go through even before you start your preparation for the exams. So this is the marking descriptor, how every response of yours is marked in the exam. As I told you, so the marks, every response is marked from 4, 5, 6, 7, 8. These are the 5 marks which is given. 4 and 5 is fail. Okay, 6, 7, 8 is pass mark. So every answers you provide or every response you give, it is assessed on these modules or subspecialties: professional, personal qualities, professionalism and ethics, surgical experience, adaptability to stress, ability to deal with gray areas, knowledge, how you justify, clinical reasoning, communication skills, organization and logical thought process, and how you practice with your patients and stuff. So every response you make is assessed on all these domains. This is where I told it's not just a matter of answering correct. It starts with how you sit in front of the examiner, how you keep your eye-to-eye contact, how is your language, how you are communicating things, how you are reasoning. Everything is assessed. Okay, and I want you all to go through this. Okay, this document is available in the website straight away, and you need to know what is considered as fail and what is considered as pass. Very, very important. Okay, now coming to the main question. Okay, so most of you here are at the beginning of preparation for your May exams or September exams. So many times we get questions whether, do I need 6 months to prepare, or do I need 3 months to prepare? Do I need to join any of these courses, or these courses are exuberantly costly? What to do, etc., etc. So you need to have a self-assessment of yourself. Okay, you need to know who you are before you decide on what you need to choose. Again, you cannot compare. There is no standard in this preparation. Okay, for section 1, I would say there's a standard in preparation. I would say 6 months, every day, 2 to 3 hours you work. That's more than enough. Okay, you study, do the questions, you will get something, you will pass. Maybe you might fail for the first time. Second time, you will understand what these questions are, you will pass. But section 2 exams, it starts from what was your experience in the last 10 years. Okay, how much ever you study from the book, it wouldn't replicate on your answers. So many times it's all based on how you have been practicing in the last 10 years. Okay, or at least in the last 2 to 3 years. So the first thing you need to know is who you are. You need to know. So you need to have a self-assessment of yourself on several things. First of all, most importantly, knowledge. You need to ask yourself, how good are you in in areas which you are not familiar with. For example, many candidates say, for example, I am an outsider in this country. When I came here, I never did a training here. My entire training in the UK is only in transplant and HPB. Never had any experience in emergency surgery here. Never had seen a breast surgery here. I never had seen a colorectal cancer here or an upper GI cancer here. So when I started preparing, I had an insight that, okay, I don't know anything except for transplant and HPV. Okay, so this you need to know, because with these questions here, as I told, emergency critical care trauma is ST8 level knowledge. It's a consultant level knowledge. So you need to know how much knowledge you need to know, how long it's going to take for you. That's the first thing you need to know. Second thing, you need to ask yourself, how good are you in talking like this? Okay, how good are you in verbalizing? How good are you in communicating what is running in your mind and things? How good are you in processing the differential diagnosis and coming out with questions and stuff? So this is a second thing, based on which you decide when is the right time for you to give this exam. Okay, so there is no 3 months, there is no 6 months, there is no 1 year. Okay, I have seen candidates 6 weeks, 4 weeks, they just come, they don't join any course, they just go, pass and come. I have seen even the trainees preparing, failed 3 times, nothing happening. I have seen senior clinical fellows or the registrars who worked 3 times, failed, they would prepare, but something would be there. So this is something you need to understand very early where you need. As I told, you need to know where you need support, whether it's in the knowledge, whether it's in the communication, whether it's in your verbalization, whether it's in your thought process. And as I told, plenty of unfamiliar territories will be checked here. Okay, you wouldn't know when was the last time you went and assessed a capacity of a patient before you did a consent for the patient. You wouldn't have seen what is the consent form you have been using when you consent a child. What is a consent form you have been using when you have been consenting a patient under local anesthesia. You wouldn't know what are the assessment forms you use. You wouldn't know when was the last time you went through your own ERAS protocol, and what do you do on day 2, say following a Whipple operation in this one. So these are all the unfamiliar territories which could be even within your specialty or outside your specialty. So again, you need to know, based on your clinical experience in the system, outside the system, you need to know where you stand. And again, not a single way is easy for everyone. I know candidates who have a very strict discipline. They can sit, they can plan things 4 months, they can make a timetable, they can self-study, and they can commit and do. There are many candidates who will never prepare in the beginning, and they go close to the exam and then they stress themselves and they do. There are many candidates who would help, who would get benefited from, okay, there is a structured thing, I will just go there, at least this will make me study, I can go there. So you need to identify which way is easy for you, whether joining a course for a long term or joining a course for a short term, or not join a course, just make self-study groups or listen to a podcast, several things. You need to know how it is. And the most important key here is speak to people who had already prepared for this exam. You don't decide for yourself discussing with colleagues who have not given this exam. You need to speak to people. You need to speak to at least 10 different people who are in a different level of knowledge, different level of communication, different level of experience at this point. When they gave this exam, how did they prepare and what they think would be the best thing for you, and go with that. Okay. And I would very strongly recommend you should join one of the courses. It's not because you need to know, and in the UK it's mandatory. It's mainly to understand this exam. Okay, many candidates, they repeatedly fail misunderstanding this exam. So you need to go any of the courses. It doesn't matter. We have a standard 4 or 5 courses in the UK. Each course has its own strengths and weaknesses. You choose which course would be ideal, and you can do and invest and sacrifice fully. Most importantly, there is no shortcuts in the preparation. Okay, there is no shortcut. You have to work hard, and you have to sacrifice your time, this one, to prepare for this exam, understanding who you are. That's the most important thing. Right. So with this background, I'm going to do some scenarios. Again, the aim of these scenarios, let me stop presenting here. The aim of the scenarios is to understand the Viva techniques. I am not here to test your knowledge, or I'm not here to criticize what you're trailing, but it is just to understand essential Viva techniques in a practical manner. So I want a volunteer. Who wants to go first? Anyone?
I can.
Fantastic, Feras. Good. Would you like switching on your camera if you don't mind, or it's okay, I don't mind, whatever you feel?
It's fine.
Okay, that's fine. Right. Imagine, Firas, you are a consultant. Okay, you are a, what specialty you are?
I'm correct.
Okay, so you are a colorectal consultant, and but you are doing an on-call for general surgery. Okay, and your unit also does has an endocrine unit, and they do endocrine surgeries in your trust. So at 10 o'clock in the night, your registrar is calling you, telling that, Dr. Firas, I have been called to see a patient in the ward who is a 33-year-old female patient who had a thyroidectomy this morning, and it's admitted in the ward. Okay, they called me stating that the patient is feeling, having shortness of breath. And I have never seen a post-thyroidectomy patient. Can you tell me what I should do? He's giving you a call over the phone. What will you do?
So I will instruct the registrar to assess the patient's vital signs first. How is the 5 vital signs: the heart rate, saturation, blood pressure, if there is any temperature or not. We'll tell them as well to speak to the patient if the patient is able to produce any voice of this, or if there is any clinical signs of a stridor.
So what is your worry here? When he calls you in the 11 o'clock, what is running in your mind?
My main concern, if the patient is having possibly a hematoma, which is accumulating in the wound site, under the wound site, or the second thing that would puzzle my mind would be a severe hypocalcemia, the potential injury, due to operation.
Okay. So how do you instruct? So this is an ST3 registrar who has never seen a thyroidectomy surgery. What are you going to instruct him? How is he going to examine the neck to see if there is a hematoma or not?
So initially, as I said, starting with checking the vital signs, try to speak with the patient. If the patient is able to speak and produce or talk comfortably, that means the patient is not in stridor. If the patient is dyspneic or unable to speak properly, that could be a stridor. And by then, I'll instruct to registrar to look at the neck and try to gently feel the wound site, if there is any tension, or if there is severe tenderness, and the dressing if there is any ooze of blood.
Okay, so he is telling that I went there. There is no dressing put in the neck. They had put a skin glue on the neck, and to me it looks normal, is what he's telling.
So I think.
So are you convinced that there is no hematoma now, if he says that?
I would ask the registrar to gently examine with the bi-digital or bi-finger examination, palpation on that area, and the gentle squeeze if there is any blood could be coming through the glue.
Okay, so what is stridor? So how will you? So he has never listened to a stridor. So how does a stridor would hear? How will you tell the registrar?
Stridor is, I think, by definition, is when the patient is having difficulty to breathe and using an extra effort to catch their breath. If that is happening, then I think the patient will be.
I am telling that this patient developed pulmonary embolism, not and that's the reason for breathlessness. Do you disagree with that or agree with that?
I cannot disagree 100%, even though I think it is maybe a little bit early for pulmonary embolism to be developed.
Okay, that's fine. So if this patient had a stridor, what do you think?
So I would think more about potential hematoma, possibly.
Why should a hematoma cause stridor?
If that is hematoma is big enough, will be retained underneath and will be causing compression on the trachea.
Do you think a hematoma can compress a trachea? Trachea has tracheal rings. Do you think a trachea can get collapsed with the hematoma? What causes stridor?
It is not 100% collapsing the trachea because there are cartilaginous rings, but
Yes.
it would be just an external compression by the bulk of the blood on the trachea.
But yeah, but the external compression on a trachea, I should say, if you put your hand and press on your trachea, do you develop stridor? When you try.
Not really. No, not really.
So what causes stridor then? So what are the causes of hoarseness of voice post-thyroidectomy?
If there is a hoarseness, that would be an injury to the recurrent laryngeal nerve.
What else? So do you think, say, for example, I did a right hemithyroidectomy, I injured the right recurrent laryngeal nerve. Will I develop hoarseness?
Yes.
Really? Is it just single side, or you should have both side injury for developing stridor?
I think if there is a unilateral injury to the recurrent laryngeal nerve, that will cause hoarseness. But if there is bilateral, that is a case where the vocal cords are completely paralyzed, and by then the patient will be having dyspnea, complete dyspnea, I think.
So what is the difference between an injury to the bilateral recurrent laryngeal nerve, where you have just injured the nerve, and the other side you have cut the nerve? What will be the difference? Imagine I have cut both the recurrent laryngeal nerve.
Yeah.
What would happen to the patient?
So the patient would be completely apneic or dyspneic.
Really? So what happens to the location of the vocal cords if it is completely cut? And what happens to the location of the vocal cords when it is injured? When I say what happens in neuropraxia and what happens in neuronormosis?
I think for neuropraxia is a transient injury to the nerve. That there will be a temporary dysfunction of the nerve.
So which patient comes to you following total thyroidectomy telling that whenever he drinks water, he's aspirating? Who are those group of patients?
I think that is possibly for the neuropraxia patient.
Okay, that's fine. So coming back to the scenario now, what are you going to do now? So your registrar is telling that, so his heart rate is 99, saturation is 100%, but they are giving 8 liters of oxygen. His respiratory rate is 22. What else he needs to do now? He has opened the wound. According to him, he could not find any big hematoma or anything. According to him.
I think I would rather go myself and assist the patient, because that is a post-op complication potentially, and it has to be a consultant reviewed for medical legal perspective, and also to assist the patient properly and make sure that whether if it is a tension hematoma or if it is a recurrent laryngeal nerve injury or if it is something else.
Okay, so you went there and you felt that the patient is in stridor, although you can't see a big swelling there. What will you do now?
If the wound is opened,
the wound is not yet opened because your registrar doesn't know what to do. You are there now.
I would think about a wound exploration, bedside wound exploration.
So what will you do?
I will open the skin and I will open the strap muscle stitches, and if there is a real hematoma, that will be expulsed out.
What is this technique called? Are you aware of the terminology for this?
I think it is called snip or snap. Something I forgot the name, but the snip or snap, like
it's called scoop.
Scoop, sorry, scoop. Yeah, you're right.
Okay.
Yeah.
Okay. You do the scoop protocol. Yeah. So you imagine you opened, there is a big hematoma. Yeah. You evacuated it. What next?
So next, I will be explaining to the patient, because I think at that time patient will be worried and will be anxious about what's going on.
Do you think once you evacuate the hematoma, his stridor would become normal now?
I'm not too sure until if the patient is feeling better after evacuating the hematoma. If the patient's stridor has gone away or start to improve, that is possibly because of that hematoma. If it is not, I will be thinking about
Okay, what next will you do?
So after explaining to the patient, I'll call the anesthetist and I will bring the patient to theater for better hemostasis control. And at the same time, I will explain to the anesthetist the situation, and to, while intubating the patient, to explain, or sorry, to examine the vocal cords if they are paralyzed, or yeah, just to assess that. And possibly I'll contact a colleague who has done the operation, or if there's any ENT consultant around, to come and examine the vocal cords and assess the laryngeal nerve functionality.
Okay, if this patient had no problems, okay, day one you're going to the ward, okay, this is on a Saturday. Forget about the scenario. This is on a Saturday. You are down to do the entire general surgery patients in your hospital. And one of the patient is day one post-total thyroidectomy. So what are the questions you will ask, and what do you anticipate?
The patient will ask about the operation. How did that go?
No. What you would like to ask the patient to assess how is the patient behaving on day one?
So I would ask the patient generally, how does the patient feel in terms of the pain, if it is manageable or not, if the patient tried to drink something or eat something, if there's any problems while swallowing, and if there is a drain. It is unusual to put a drain for thyroidectomy, but if there is drain or not, I will have a look at the drain.
Anything else you would ask for? So what are the complications you'd expect on day one?
I would expect. I would ask the patient if the patient feels numbness or around the mouth, or patient feels any potential signs of hypocalcemia.
So what are the signs of hypocalcemia apart from numbness around the mouth?
So if the patient feels, as I said, numbness, or feeling weakness, and yeah, patient feels tired, feeling tired.
Okay, imagine you went through the operation notes. Okay, this patient had underwent total thyroidectomy for a medullary carcinoma thyroid. Okay, so if a patient had a medullary carcinoma thyroid, what other cancers could have been associated with that?
So we'll be assessing for men too. So for medullary thyroid carcinoma is could be parathyroid cancer, or could be pancreatic cancer.
So pancreas comes in men too?
It is PMP, like yeah, it is medullary cancer, parathyroid, and pancreatic neuroendocrine tumor.
Is it not pheochromocytoma?
Oh, sorry, pheochromocytoma. Yeah, apologize.
Fine. That's fine, no problem. I'm going to stop here. Okay. So how did you do, Firas? What do you think?
Not the best. Yeah, I think I need to be more prepared, and I need to be more mentally.
If I had not personally known what is this exam, if I am listening to you, I'm pretty sure most of the others in the group would tell that, oh, you know a lot about thyroid operation. This is what everyone would feel. Okay. If I had not known what is this exam, oh, Firas is excellent, I might question you, are you an endocrine surgeon? Okay. So that is how you answered. However, so what all things you should have done. So this one, I would say a borderline pass or even a fail, okay, in the exam for various reasons, I will tell you. Okay. So now let me share my screen again to see what all is essentially looked into in this, and I will explain that. Let me share my screen. Fine. So if you see here, the first important thing is the higher order thinking. Okay, so clinical justification and logistic thinking. So in this scenario, how this would be assessed is, the moment this registrar calls you, or this scenario is given in the exam, you need to tell that I am extremely concerned about the situation. Okay, you need to tell that unless proved otherwise, the first differentials which is running in my mind is a post-thyroidectomy hematoma and patient is having stridor. However, the other differentials include hypocalcemia, patient having breathlessness, patient could just have an aspiration, patient could have developed an early ventilator-associated pneumonia, patient could have developed a pulmonary embolism, or it could just be an edema following an intubation. These are all the differentials in my mind. And when this registrar calls me telling me that this patient is, so this particular registrar has not had an experience before, I am extremely concerned about the situation. I would call the registrar to put away an emergency call. This is what I would say. That is how you behave safe at 11 o'clock in the night, because you cannot assume things when someone tells that I don't know, and you cannot be instructing. Yes, of course, if you are down in the ground floor, if you're going there by yourself, then it's fine. But in this situation, I would not take chance in this situation, because a post-thyroidectomy hematoma would kill the patient immediately. I would ask him to put an arrest call, or even an emergency critical care call. Okay, so the CCOT team can come, or an arrest call team can come. Let them come, and the people who know, let them come and assess what is happening. This should be your first step, where you had expressed your higher order thinking, you had expressed what knowledge you have in seeing this patient so far, and you are justifying all your actions, and you are using your logistic thinking of why these are the possibilities. Most importantly, you need to be safe. Any answer in your exam, I can take it in telling that you are behaving in a serious harmful manner against the patient. I can fail you. In this, because you took so much time in asking your registrar, who is very, very ignorant about these problems, asking them to assess all these things, I would say he is very unsafe. I don't want a consultant like him. I don't want to sign him off. I can tell that. I can also take in a way that, okay, no, he is behaving rightly only. He is trying to triage which level of care the patient needs. So this is completely in my jurisdiction to decide how you behave. So playing safe, but you need to assume that the worst examiner, all the examiners sitting in front of you is worst, is what you need to assume, and you need to be 100% perfect. Okay, so playing safe is very, very important. Being accountable, you are responsible for everything happening to this patient. So you would say that I will go myself. In the meantime, I will call for help. My registrar will call. Now, next comes the guidelines. Here, the knowledge and other things come. So you would tell that, so this patient needs an assessment based on the CRIS protocol. So any care of a critically ill surgical patient, we follow CRIS protocol. Although we never write all these things in our day-to-day practice, for the sake of this exam, we need to hear these words from you. You would tell, I will follow the CRIS protocol. If you are there already, I would follow the CRIS protocol. I will quickly do an A to E assessment. Okay, and then I would see. Next comes the knowledge aspect question, whichever I asked. Why does a post-thyroidectomy, so what is a stridor? So stridor is a noisy breathing. Okay, there is a secondary to an airway narrowing. Okay, and the stridor following post-thyroidectomy bleed is not because of tracheal compression, but it's because of the vocal cord edema. Okay, so whenever there's a big hematoma there, the hematoma can press on the recurrent laryngeal nerve, causing a pressure injury to the nerve, resulting in vocal cord edema, also bringing the vocal cord into almost to the midline, causing as narrow as possible, which is a median position. Or this hematoma can cause compression to the vocal cord's drainage, and vocal cord can become edematous and can narrow it. This is the reason for stridor, and stridor comes with incomplete bilateral damage to the recurrent larynx. If you have cut both the nerves on both the sides, the vocal cord will go to a paramedian position, where the patient would still be able to speak, but they would not have a good tone to their voice. But the most important problem they would have is aspirating whenever they take liquids. This is what will happen in bilateral complete recurrent laryngeal palsy. Bilateral incomplete recurrent laryngeal palsy, the vocal cords come to the median position. Okay, and again, if I know that you told rightly that I look for a hematoma, I would prove this, but what we need to hear is I would follow the scoop principles. Although it's very simple, it's a skin, cutting the sutures, opening the muscles, evacuating and theater and whatever, but we need to know this. It's not because we want you to tell this, but we need to see whether you had ever roamed in an endocrine ward where this is put in every other walls. This is what we need to check. And ability to deal with the gray. You are a colorectal surgeon. Okay, you are a colorectal surgeon, and this is an unfamiliar territory for you. I don't know when was the last time you had ever seen a thyroid, or you had ever seen a thyroid at all. Okay, so this area, again, your aim is to keep the patient alive. That's all is your aim. You are not doing anything more than that. You open the wound. Here again, you need to tell that if the patient is stridor, step 1 is intubation. Okay, you need to intubate the patient, protect the airway, open the wound. That's all is your job. Okay, in the meantime, you will call your registrar to speak to the surgeon who operated and tell this situation, and you want that endocrine surgeon to come here to do whatever is essential. This patient's re-exploration you are not doing, because you might go there when there is an incomplete recurrent injury. You might go and bust everything, and you can cause full injury if you have never encountered that territory. So that might again be considered as unsafe. So we want the person, your aim is care of a critically ill patient from not dying. That's your aim. Okay, and how to respond to a stressful situation. Okay, so although I behaved in a very simple way here, I might question you, do you think your registrar, what if your registrar goes and misses a hematoma there? He can ask you like that. So that is to pressurize you to tell that again. So that's why we say you need to follow and in a very, very safe approach. For the sake of exam, whenever something happens, you will tell, I will go myself. Okay, the examiner will tell, no, you are staying 30 minutes away, you are off-site, your only registrar is there. You will tell, I will start my journey towards the hospital. However, I will ask my registrar. I would know whether my registrar is competent enough to handle the scenario. If I think that he is not competent enough, I would ask him to call for help immediately. Okay, so these are all the things we would look into in a simple scenario like this. Do you agree with me, Firas?
Yeah, totally.
Any questions from others? Any difference of opinion? Anything? Yeah. So this is again, I just want to make you present. What the knowledge he had is absolutely fine. In fact, that's more than enough. Yeah. But what we expect is this. Yes, Amit?
Yeah. So you said endocrine was also in the same hospital. So probably we can ask if there is an endocrine on-call as well.
Yeah, of course. Means that's how it works. In the exam, you will have a scenario, for example, okay, so you had a trauma patient. Patient is crashing. Okay, he's not even fit enough to do a CT angiogram or anything. You took the patient to theater. Okay, and you did a laparotomy. There was a splenic injury. You did a splenectomy. There is an expanding retroperitoneal hematoma, and you suspect, say, IVC or aortic injury. You would tell that, oh, I will call my vascular surgery colleague. Okay, the examiner will tell, no vascular surgery colleague available. What will you do? This is exactly what would happen. Of course, your aim first is to see if there is an endocrine surgeon around, or if there is an endocrine surgery on-call person. However, the 100% answer from the examiner is no, you are the general surgery person. You are doing the night on-call. The endocrine surgeons are not rotated to do the night on-call. What will you do? So this is how they would answer. Yeah. Any other questions from others? In this scenario, particularly, just to understand the Viva and stuff. If you have any question, yeah, yes, Firas.
If the comment that there is no rota for the endocrine surgeon and the surgeon who did the operation is not available at night, so
no. See, in that situation, you had to. It's not always a situation where you don't call a person. You of course you tell, even if there's no one rotated, you have to ring the person, whoever knows. So you need to show the examiner that you did everything possible to get an appropriate help for this patient. Of course, if no one is available, you would tell that I have tried my best. My aim now is to save this patient's life. I will take this patient to theater now. This is how you answer. Okay. One of the very common scenario in this regard, which will come in the exam, is patient presenting with acute limb injury, acute limb ischemia. So patient coming with acute limb ischemia, okay, CT done. So this acute limb ischemia, the treatment is you need to do an embolectomy. You will tell, okay, I will call my vascular colleague. your hospital is a district general hospital. You are the general surgery consultant. There is no vascular. Okay, I will call for help. I'll speak to my nearest hospital. They'll say, the nearest hospital is 3 hours away. They'll say, what will you do? Okay, so in this situation, I'm left with no option. I have to take this patient to theater to do an emergency embolectomy, and you are supposed to do an embolectomy in that situation. So this is how, so you need to express what is running in your mind. You need to express that you tried your best to offer a safe service to the patient. At the end, you need to tell that I have lost all the opportunities. I don't have any more options. I will go and do myself. This is what you do. Yeah, Firas?
Thank you.
Perfect. Good. Right. So who wants to do the next scenario?
Yeah, I can do.
Yes, Adil. Good. Adil, imagine you are a consultant on call and there is a patient who's brought to A&E. This patient is a 60-year-old patient brought by his 2 daughters. This patient has been having learning disability since birth. Since birth has learning disability. And the main complaint of this patient is patient has not opened the bowels for 10 days and has vomiting for the last 2 days. How will you approach the situation?
All right, thank you. Well, this is obviously a life-threatening situation. I will approach the patient based on the CRESP protocol going from A to E. I would try to obtain a focused, detailed history regarding the symptoms. I will also examine the patient while monitoring the response to resuscitation according
So
to
this
the
patient, you
ABC.
go there, this patient doesn't speak at all. He has a significant
Yes.
learning disability and doesn't speak anything.
Yeah, I will try to obtain a collateral history from the carers or the 2 daughters or whoever basically is caring about the patient. Try basically to find out when the
The
symptoms...
patient daughters are telling that he lives in a care home, okay, and he has a 24-hour-by-7 carer. However, their daughters are telling that we know that he has been suffering from chronic constipation, and we were told that he didn't open bowels for the last 10 days, and he has been crying for the last 2 days and vomiting for the last 2 days.
Yeah, of course, yeah. After making sure, taking the good history and doing the examination to see if the patient is peritonitic, I will...
What examination you would like to do?
I will basically start with abdominal examination, looking for signs of bowel obstruction like distension, looking for complications of the problem like peritonitis, looking for any signs of hernias that could be basically obstructed or strangulating. Digital rectal examination is part of the abdominal examination.
You examine this patient. The patient has a very grossly distended tympanic abdomen. Okay, and this patient in front of you, he vomits bile. Okay, but attempts have been made by the nurses there to put an NG tube. However, patient is not cooperating at all.
Okay, well, this is obviously, again, is a concerning situation where the patient could aspirate, basically. I will try to give the patient anti-sickness and try to put the NG tube by myself. I will basically consider here the possibility of large bowel obstruction, most likely is due to volvulus because of the constipation, or organic lesions like cancers, or basically bowel ischemia.
Okay.
I will...
What next? What do you want to do?
Yeah, checking the response to the resuscitation, ordering some routine bloods and lactate, and arranging for a CT scan
So
of the abdomen and pelvis.
This patient, you think that he's not going to cooperate for a CT scan. He's just moving this side and that side. You can't do a CT scan.
Well, in this case, I will speak to my anesthetic colleague to possibly help me, making him more comfortable by giving him sedation during the scan, and basically see what the scan comes back as, and take it from there.
Right. So this patient, in the meantime, while waiting, someone has suggested let's do an X-ray. Okay, and this is the X-ray of the patient. Tell me, what do you see here?
Yeah. This is basically an abdominal X-ray showing large bowel dilatation, mainly on the left side, with possible coffee bean sign. Yes, coffee bean sign. There is no gas down in the rectum, which basically indicate that there is large bowel obstruction. There are no clear free air under the diaphragm, which at least primarily reassuring for no signs, no perforation in the bowels at the moment.
So what is this what is your diagnosis?
It's most likely basically sigmoid volvulus.
Why do you say sigmoid volvulus? Apart from the look of the bowel, anything else which is suggestive of a sigmoid volvulus?
I think basically in terms of the X-ray here, the coffee bean sign.
How does, so if it is a sigmoid volvulus, how does the rest of the colon would be? The transverse of the cecum and other things, how will it look like?
They wouldn't typically, they wouldn't appear on the X-ray. They would be collapsed.
Really? In a sigmoid volvulus, when a sigmoid is obstructed, the ascending, transverse, descending colon all will be dilated, isn't it?
Yes. Sorry.
Yes,
Yeah,
sir.
they would be dilated. Yeah.
Yes. What do you see here?
So,
is there any dilatation? So you can see the descending colon, which is collapsed here. There is some colon or whatever, but you can't see the grossly dilated rest of the colon, which is dilated, isn't it?
Yes.
So what
and
do you
also
think?
there is also a segment of small bowel dilatation in the center of the abdomen, which might indicate that there is incompetent ileocecal valve causing back pressure and dilatation of the small bowels.
So what is this then, if not a sigmoid volvulus?
It could be in his condition, could be an organic lesion like cancer here.
Cancer? How can it be a cancer? So do you agree that this whole thing is colon or not? This one is colon or this is one is small bowel? What is this?
I agree it's colon.
Yes. So so if it is an organic lesion like a cancer, where do you think this cancer should be?
I think it's definite. Well, I think it's at the distal sigmoid upper rectum.
So if it is at a distal sigmoid upper rectum, you would expect the whole colon to be dilated, isn't it? Have you ever seen a collapsed colon with just a segmental dilatation, unless you have two cancers causing a closed loop obstruction, which is very unusual? Anything else it could be? Again, you need to understand that cancerous obstructions, you will never have this big a dilated colon. You know, cancerous obstruction, they are all very, very quick. And the bowels will not have enough time to stretch and distend like this. Whenever you have grossly dilated bowel, you need to suspect a benign pathology. The same thing holds good even for stomach. So in a gastric outlet obstruction secondary to a cancer, the stomach will not dilate it massively. But a gastric outlet obstruction secondary to a cicatrized duodenal ulcer, the stomach will be massive because it is a long-standing process. So what else it could be?
Diverticular stricture.
How come diverticular stricture can cause this? You mean tooth strictures? Why are you not thinking about the other common volvulus?
Could be a cecal volvulus.
Exactly. Can it be cecal volvulus?
Yes, it can be a cecal
Exactly.
volvulus.
This is a cecal volvulus. Okay. So the cecal volvulus and sigmoid volvulus most of the time looks exactly the same in the X-ray, with a big dilated bowel loop with the coffee beans. And many times it would be very difficult looking at the bowel alone. But what you need to look for is the rest of the intestines. The rest of the colon, if it is grossly dilated, this is an sigmoid volvulus. If the rest of the colon is all collapsed, this is a cecal volvulus. Cecal volvulus is a very, very common question in your exam. So what are the types of cecal volvulus? How many types are there?
I can't remember the classification, but I think there are 3 or 4 types of cecal volvulus.
Fine. So this patient, with the X-ray only, the radiologist calls you telling that this patient looks like a cecal volvulus. You don't need to do a CT scan is what they are telling. Are you happy with that, or you still want a CT scan?
No, definitely, I'm not happy with that. I would definitely emphasize on the need of the CT scan.
What does CT scan add here?
A CT scan here will basically gives more details about the cause of the cecal volvulus, if it's cancer related, and also basically if it's cancer related or as a cancer as a cause, basically we'll look for the signs
Can
of
a cancer cause a volvulus?
yes.
Really?
Yeah.
Okay, fine. So you did a CT scan for whatever reason. Okay, the diagnosis is same, cecal volvulus. Any other information? So I am the radiologist. You can ask me if you need any more questions from the CT scan. What other information you need from me?
I would like to know if there are any signs of perforation.
No
I would
perforation.
like to assess basically the viability of the bowels.
Okay.
I would like
The
to look
entire cecum is grossly dilated, cecum and ascending colon grossly dilated, and the bowel wall is thick, but the bowel wall is still enhancing.
I would ask for basically to check the blood supply to the bowels and make sure that there is no basically vascular basically pathology like thrombus or embolus in the main mesenteric blood supply.
Okay, fine. Okay, no other findings. What next now? This is your diagnosis.
Yeah, so basically, this is again is a life-threatening situation, and urgent action is required to manage this patient. Since the patient has learning disability, I will make sure basically that the carer understand the the main carers understand the diagnosis and the need for the urgency management. I will try to see if they have any advanced decision, if the patient has an advanced decision or lasting power of attorney, and if the carer is able to make decisions on the patient on behalf of the patient or not. Then, if they agree, I will offer the patient basically. As a day one consultant, I've never done this laparoscopically, so I will offer the patient a laparotomy and right hemicolectomy.
And
Right
you'll give an
hemicolectomy.
anastomosis or you give a stoma?
I will assess the hemodynamic stability of the patient intraoperatively, and if there is no contraindication to join the patient, yes, I will join up the patient.
Fine. So this patient family says that there is no advance directive from the patient and no one has power of attorney.
Well, I think in this case, I will explain that this is basically going to be in the best interest of the patient, and we should proceed with the surgery. And I will basically provide them with more information.
How do you consent when you say proceed with surgery? Who's going to consent the patient?
It's me, and it's gonna be doing forum number 4.
Okay, very good. Fine. So my question is, how do you know, okay, this is an emergency situation, but how do you know that you are doing right thing for the patient? When will you decide to palliate this patient?
I will basically palliate this patient if he has an advanced decision.
No, there is the same situation, no advanced decision, no power of attorney.
Yeah, I will basically palliate this patient if he is not fit to have such major intervention. I will basically do the scoring system like
what scoring system?
the NILA scoring system. I will assist and obtain data information about the patient performance status and past medical history to see. I will assist
what does NILA score tell you?
The NILA score tells you about the risk of mortality from the surgical from the laparotomy.
Okay, beyond what percentage you will tell that I'm not going to operate?
I have no idea.
So what's the difference between NILA score and the parsimonious NILA score?
What's the second one, sorry?
Parsimonious NILA scoring, that's what we use now, isn't it?
We still use the NELA score here.
Really?
I've never used the other. Yeah, I've never used the other score.
But whatever you have been using now is the parsimonious NELA scoring only. The previous
Yeah.
NELA scoring, whatever we were doing, gives both morbidity and mortality. Okay.
Yeah.
Now the present scoring offers you only mortality, isn't it? It doesn't give you
Yes.
the morbidity score. That's the new updated version of the NELA score, which is called the parsimonious NELA score. Now, going to the last question to you.
Yeah.
If by any chance you think that this patient is stable, okay,
Yeah.
he's a surgical candidate according to you, yes, he has learning disability, but the patient's daughters have the power of attorney. Okay,
Yeah.
they have their power of attorney, and they're saying that you need to palliate this patient. We don't want him to have the surgery. What will you do?
I will basically explore this option with them. I will see the rationale, the reasons behind this decision. I will make sure that the carer, the daughter decision is going to be in the patient best interest. And if
No, this
all of
patient has a
these,
power of attorney, and you, according to you, this patient would benefit from surgery. The doctors are telling we have the power of attorney. We would like to palliate him.
so you think that the patient will benefit from surgery?
You think that by your assessment, you think that patient would need surgery, but
Yeah.
they are telling that we have the power of attorney. We have been making decisions on his behalf. We don't want surgery.
I think basically, again, I will, I will, yeah, I will challenge their decision. I will explain
Yeah, you had explained everything, doctor. We have been taking him to the hospital several times. We have been making decisions on him. He had suffered a lot. We just want him to palliate. We have no more energy to look after him. This is what they're telling.
Well, I think in this case, I would. I've never been in such situation. I will make sure that I'm doing the right thing. I will speak to a senior colleague and see if, and my legal team in the hospital, to see if their decision is the right thing to do in such situation.
Excellent. Good. So imagine the same situation is happening in your clinic. Okay. You have a patient who's coming to your clinic who's diagnosed to have a cecal cancer. Okay. Cecal cancer, and apparently no one has, this patient doesn't have an advance directive. Okay. And no one has a power of attorney for this patient. And this patient, you think that patient would need a radical right hemicolectomy. How will you consent this patient now?
With learning disability too, right?
Yes.
Yes, so I think it follows the same principle. That's going to be in the patient best interest. If the patient is fit to have an operation, then I would consent them via form number 4.
Have you ever done an elective operation using a form 4 consent?
Yes.
Really?
Yeah.
Then it's wrong. You should not do. So what is form 4 consent?
It's for.
Have you ever gone through in between the lines of form 4 consent?
Yes, sorry, it's for emergency interventions.
Life-threatening situations alone. Okay. If you
Yes.
see the line there, are you pretty sure if you wait for some more time where this patient achieves a capacity, or you could appoint someone, if you can't wait, only then you need to put. No elective operations are done with form 4 consent. Okay, you will be penalized. So how will you do then? What will you do in this situation?
Well, I think basically the carers will need to apply for power of attorney,
That
or
will take 3
basically
months.
ask. Okay, then in that case, then I will ask for best interest meeting, and
So who is
IMCA?
What is IMCA?
Independent mental capacity advocate.
Fantastic. Good. Good. Okay, I'm going to stop you here. Okay. How did you do, Adel?
Well, again, not the best.
It's okay. It means you did well. So again, few things which I want to let me tell you the good things. Your pace of answering is very good. Okay. In this exam, again, most important thing is you should not underplay, you should not overplay. These are the two things which is very essential. When I say underplay, you need to give a complete answer with your reasoning. Okay. For example, what do you think here? You should not just tell, okay, cecal volvulus. You should not just say, but you should say, okay, it looks like this and this, so I think it's cecal volvulus. So this is called properly answering. Some candidates, they think that they are very smart. They want to impress the examiner straight, and they will answer the answers for the next two questions which they anticipate from the examiner. So they would say, okay, this looks like a cecal volvulus. I think this patient, I will consent and take the patient to theater. Okay, so that is called overplaying, and which is very, very harmful in this exam. So your answering skills were really good. Your tone was really good. That's all fine. Okay, but of course, you know, in this exam, you would at least closely you will be interpreting 10 to 12 images minimum in the six sessions, maybe more than that actually. So you will be given ranges of images starting from X-rays to CT, MRI, PET scans, SPECT scans. You would be given, ERCP images. Anything could be given. Okay, especially if you are a colorectal or an upper GI surgeon, you would be given an endoscopic ultrasound of esophagus, endoscopic anal ultrasound. All these things could be given. So interpreting the image, how do you interpret the image, is very, very vital. So there are different techniques for different kind of images. You will tell this an X-ray, plain X-ray, blah, blah, blah. This is what you see. This is what you see. Obviously, anyone who would have seen this X-ray in this group, most of you would have thought it's a sigmoid volvulus. Okay, again, unless you had ever seen or handled a cecal volvulus, you would never think about cecal volvulus in this situation. But this is a case of a cecal volvulus, and there's no thing. Again, very common questions in the exam is types of cecal volvulus. When will you operate? Is there any other role of intervention without a resection? When do you do cecopexy? If at all, if you want to do a cecopexy, can you do ultrasound guided cecopexy or a surgical cecopexy, etc. So again, here different things are in this one. So of course, you had discussed about higher order thinking and knowledge. So this patient, when he came, the first answer I would have told is, you started telling, you were right that telling that you will go there, follow the CRISP protocols. I would have told that this is a very difficult situation where on one side I'm having a patient who has a learning difficulty, whom I presume that may not have capacity. So my clinical examination and diagnosis in this patient is going to be difficult. On the other side, I have a surgical emergency, which could be an intestinal obstruction, which could be because of a cancer, volvulus, hernia, etc., etc., etc. Or in this patients, you never thought about Ogilvie syndrome, non-dynamic, adynamic obstruction, because these are all the patients who are more prone to develop adynamic obstructions in the form of paralytic ileus or, Ogilvie syndrome or colonic pseudo obstruction. So these are the things which will be running in your mind. Then you go there, you follow CRISP protocol, which I completely agree. Then the knowledge things which we discuss. In this exam, you will have at least 2 or 3 scenarios where the aim of the scenario is to assess how you deal with vulnerable patients. The vulnerable patients, the list of vulnerable patients includes patients with learning disability, patients with dementia, patient who doesn't have capacity, kids coming in, whether they have, they are Gillick competent or not, patients with Jehovah's Witness background, or kids surgery where 2 parents having different views about the surgery, how do you consent, etc., etc. And having a very unwell patient where the family and the patient himself is pushing you to take up the risk and undergo the surgery. However, you feel that the surgery would be futile for this patient. So these are all different range of scenarios which can come in different combinations in the exam, and we would see how you deal with this, understanding the guidelines and principles within the NHS. Okay, again, here you need to play very, very safe. At the end of the day, you trying to help the patient, and you should not end up in court. Okay, and again, there are plenty of gray areas here. Again, learning disability, any patient who comes, you need to know what is the level of the learning disability. And from time zero, you should involve your learning disability nurse, which every hospital has. So they would come, they would have special skills and techniques to get obtained and communicate with this learning disability, because learning disability patient is different from dementia, is different from patient who lacks complete capacity, etc., etc. So you need to involve the learning disability nurse, and how do you make decisions? Okay, and consenting, that's again a very common question which would come. How do you decide when you choose Form 4, when you should approach the court in making any decision? So all the elective situations, you approach the court. All the emergency situations, you make decisions. Again, as one of the questions which I asked, where say the family members has the power of attorney, and do you think that they are making decision which is harmful or against the best interest of the patient? Here you need to tell that I am not comfortable accepting the decision made by them. I would ask for help. So whom you can ask for help? You can ask your clinical lead, you can call your safeguarding team from your hospital, you can alert them, they can come. You can call the chief matron of the hospital, they can come and they can make decisions on your behalf. And you will never take decision by yourself in these situations. Okay, good. Any questions? Adel, any questions? Do you agree?
I completely agree. Thank you so much for clarification.
No problem. Firas, tell me.
Thanks for that explanation. It is just one of these gray area, and it is quite confusing.
Exactly.
I'm not based in England, I'm based in Scotland. And we have a different process about the consenting. We don't have consent 1, 2, 3, and 4. In such situations for vulnerable patients, and we came across, I remember we came across in real life one like that, the patient's family, who is power of attorney, is not willing to look after the patient, I think for financial interest or whatever. And that was a very tricky question, and it was an emergency at the night, and we struggled indeed, because we needed to wake the clinical lead from sleep for that situation. So I don't know what is the right way to crystallize the answer in a right way. So
if you are, say, for example, you have a patient who you say has an ischemic bowel, who is surgically otherwise fit, unable to give a consent, and however the patient are telling no, you would tell that this is a very difficult situation. This patient, the family members doesn't have the power of attorney to make decision on this patient, on this behalf. I am going to react based on the best interest of the patient. I will explain the patient, explain the family members that we have to take this decision. We are taking this patient to theater. We will make sure this patient is supported. If you think you cannot look after, we can. That's how we do it in the England. I think it should be the same in Scotland as well. So we will make sure, if it is really indicated, we can identify community care home or community care service, and we can. But you will not go against this decision. Okay.
I mean, against the decision of the
family.
Of the family,
yes,
or the power of attorney, if they want the patient to be palliated, but you still feel that the patient, they can benefit from the operation, and you have an ICU consultant support about this decision as well.
Yes. So see, again, that's a very nice question. If someone has a power of attorney, okay, if someone has a power of attorney, and if you think that they are making a logical decision, you cannot go against them, unfortunately. You have to respect their power of attorney. Only in a situation where you think that they are irrational in making decision, or you think that they are not understanding the seriousness in making a decision, then you can ask for help. At any cost, you are not going against a person who has the power of attorney, who makes a decision. You are not going against the decision of a person who has the power of attorney for the patient. No. Yeah.
Thank you.
Yeah, the same thing applies. For example, very common scenario in the exam is a pediatric patient brought in to A&E with a trauma who needs blood transfusion, and the family are running in and telling that we are from Jehovah's Witness, you should not transfuse blood. What will you do in that situation, Firas?
Yeah, for this situation, I think it is mentioned clearly in the GMC website and in the Royal College website about these situations, to go with the patient's best interest, which is life-saving
Fine.
intervention,
So
including
this kid is 15 years old, okay, and this kid is very knowledgeable, okay. He is telling that I know what is, I am very religious, okay, I want to follow the principles of Jehovah's Witness. I don't want blood, okay. And you are very comfortably assuming that, not assuming, you are very confident that he is Gillick competent. He is Gillick competent, and he says no to blood. What will you do?
Well, in this situation, I think as long as the patient is Gillick competent, I would respect his decision. If is very adamant about his decision to not get the blood, and I cannot move forward with that.
That's wrong. Okay, so Gillick competent is something. Yes, Amit, you want to tell?
So the Gillick competence is only about the consent for procedures, but for blood transfusion, I think it's age of 18.
Okay, no.
So if someone
no. So, okay, Walid, let me ask Walid, and then I will tell. Walid, what do you think?
I think Gillick competent is for accepting, but Gillick competent is not for refusing things.
Excellent. That's the thing. Okay. So Gillick, for example, say a kid needs an appendicectomy. Okay. 14 years old, you're going and explaining that, dear kid, this is the problem. These are the things. Oh, okay, fine. I am asking you questions. Oh, doctor, so will I have this pain here? When can I go to school? When can I start playing? That is how you assess, okay, he has the ability to understand whatever you're asking. He has the ability to reason his decisions, and he is able to retain the information and reproduce, okay. So you assume him that, okay, he is Gillick competent. He can just sign the consent form for himself. You do the operation. Now, you are going and telling the same kid, he is asking so many questions, and it's a perforated appendicitis, and he is telling that I understand everything, I don't want surgery. Then you cannot. You have to still go against the kid's Gillick competence here. You have to take him to theater and operate. Okay, this is how Gillick competence work. Gillick competence is only to accept an situation which is at the best interest, not to deny and or go against whatever is appropriate for the patient. Okay, again, you will have plenty of scenarios like this in the exam. So these are the things. So if you understand, these are all you might think that this is all very simple day-to-day clinical practice scenarios in your exam, in your practice. But however, none of us would have known what is the right answer unless we prepared for this exam. Okay, and these are the things which is commonly checked in the exam, and this is all the areas which you as a consultant will be dealing when you make decisions, or coming back as problems where you deal with the complaints. Okay, so that's why you need to know, and that's why this is all tested. Right, let us move on. Any other questions from others here? I will do one more scenario and probably move from there. Anyone who wants to do next? Walid Noor, you want to do? Walid Noor? Okay, Muhammad Naifi. Yeah. Perfect. Mohammed, again, you have started your career as a day one consultant. You are a consultant surgeon from today, and today is your first general surgery list, okay? And you are very happy there, so you have no more you need to go and consent the patient. Your registrar has gone down to consent the patient, and then you are telling that, okay, from today onwards, I'm going to train my registrars. You are telling your registrar, start the operation. I will join you. This is the patient who had a right-sided inguinal hernia and being planned for an open right inguinal hernia repair. You now go to the theater, okay, and you see that they have started the operation. However, you see that the registrar had made an incision on the left side, okay, and he is almost looped the cord now, okay, and you are going there and you somehow vaguely remember that this should be a right-sided hernia. You went into the clinic letters, which clearly states that patient has a right inguinal hernia, and the patient's plan in the clinic is to do a right open hernia repair. What will you do now?
So first of all, I will stop my registrar.
Oh.
I will check if there is site marking or not.
Mm-hmm.
To see if the site marking, I will check the consent again.
Okay.
And if I found that this is right inguinal hernia,
mm-hmm.
I will stop my registrar, close the left side, operate on the right side. After that, after the operation, we'll do There is a responsibility of Kandover.
Okay, so before that, okay, you go there. That's again. So this is what I told you. So you should not go for the fifth question, which I am going to answer. Question you. Okay, so we are still in the first question. So you went there. You stopped the registrar from operating. You see that your registrar says, yeah, I examined, the hernia is on the left side. He has put a mark on the left side. Okay, he has put the mark on the left side, and he has consented the patient for left-sided open inguinal hernia repair. Okay.
Yes.
What will you do now?
So where he in the surgery?
So he has opened. He has the external oblique is open. He has looped the cord.
And the patient is consented for left-sided inguinal.
Yes. Yes.
So in this scenario, if he's consented for left-sided inguinal hernia, and if I find hernia, I'll fix that hernia.
Mm-hmm. You go and see there is no hernia on the left side, no sac, nothing.
I will close the left side, go to the right side, and fix the hernia on the right side.
Mm-hmm. Mm-hmm.
You want me to go to the next step, or?
Okay, so you have operated on the right side. What will you do in the next step?
Next step, I will write incident report
Mm-hmm.
to explain what happened. And
before you go to the next step, I want to question you. This patient has consented for a left opening inguinal hernia repair. How can you operate on the right side without the patient consent?
Because of letters from clinics, that's the right side hernia, and he has.
Okay, the letter also says that I have right sided gynecomastia. Will you do gynecomastia operation?
No, the discussion was about hernia.
Yeah, but how can you decide? But I have not consented. I consented to an explanation given to me that it is a left-sided inguinal hernia, and I have consented for left open inguinal hernia repair. How can you do on the right side without my consent?
Because of patient best interest, but this is not emergency. It's not applicable in this situation. But because the patient already is having his GA and having the risk from GA.
Mm-hmm. Fine, that's okay. So imagine you repaired on the right side. Okay, you've opened the right side. There's a large direct hernia. You had put a mesh. Okay, what happens after that?
Again, writing incident report or the text, explaining what's happening after the patient wake up. I will explain to him what's happening, apologize. After that, if he's fit for discharge, or discharge him following apology letter for the patient.
Patient is fuming there. Patient got so irritated. He's telling, how can you behave like this? I'm going to sue you. What will you tell?
I understand his frustration, and I will apologize and explain my concept behind fixing his right side inguinal hernia.
So what will be the follow-up for this patient? This particular patient. What else you will do? You had put a datex, you had put an incident report, you have apologized to the patient. What else?
Candor duty.
Yeah, duty of candor you want to do. What else?
Letter of apologies.
Okay, anything else? What do you think has gone wrong in this case?
So we can do case root analysis to understand what happened wrong in this case.
What do you think has gone wrong here?
So we start with from my responsibility to check the patient before the operation as the operating consultant. This is one of the major mistake. So it's my responsibility. After that, the consenting registrar he has the knowledge to consent the patient or no. After that, did he review the letters or no?
So whom are you going to blame apart from you and the registrar? Anything else? Anyone else has to be blamed here?
yeah, WHO checklist should be checked. So I will have to look to the operation list to see if this is patient was put as a right or left.
In the operating list, it's written as open inguinal hernia repair.
Okay, this is also my mistake, and this is admin mistake. But if it's just written as open inguinal hernia, I think the in charge nurse should not accept this list because it should be clearly stated it's left or right.
Okay.
So it's and when we do the sign in, the anesthesia should ask the patient with the nurses about the site of surgery. So there is a cycle of errors here, starting from my side and extending to the nurses in charge, registrar, admin, in charge nurses. And
but who do you think is the ultimate responsibility in the situation?
Of course, me.
Fine. So you have done all these things, okay? And this is your day one of your career as a consultant, okay? Now, this is a new trust where you have joined the consultant body. And how are you going to gain back the confidence on you by the rest of your team? What will your rest of your team will think about you today? So how are you going to gain back to who you are? What steps you will be doing in the future now?
So I will do case root analysis to understand what's happening, and I will start to audit my work to see if I can, and I will put pathway to prevent this from happening again.
So what new pathway are going? There are several pathways already. Why do you want to introduce new pathway here?
It's for myself, first of all, to check the operation list before I send it to the theater by myself, not my secretary. I should know who the registrar is working with me. What is the level of the registrar? Is he capable to consent patient or not? And ideally, before any patient is elective surgery, before patient going to sleep, I have to check by myself. The registrar can do the consent, but I have to check the consent.
Okay, fine. Okay, I'm going to stop here. Okay. Walid, you were raising your hands. Any difference of opinion you had, Walid?
Yeah, first of all, I will stop the operation, and I will close the wound myself, and not operate in the other side.
You won't operate on the other side, even though his problem is on the right side.
Yeah, I will not operate because the patient is not consented for that side.
Okay.
And I will not create another problem. So there is already problems created.
Okay. So this patient wakes up. Okay. Wakes up and you're explaining that. So unfortunately, there has been a mistake happened. You had a right inguinal hernia. However, my junior doctors consented you for the left side and you had signed for the left side. And so we have just closed. Sorry about that. And he becomes fuming, telling that, oh, doctor, you know that I have right-sided hernia. Now I am under anesthesia. I was under anesthesia. Do you expect me to undergo another anesthesia for this? Is what he's asking.
I will tell you that I will take the full responsibility.
Yeah, you take the responsibility, but I am the patient who's suffering. What will you do? Now, what will be? So you take the responsibility. I completely agree. My question is, I was under anesthesia. Okay, you could have just fixed this. I'm glad that okay, a mistake has happened. Now you are punishing me for the second time, stating that I need to come back for another day, sort out this pain, and go into anesthesia again, sort out another pain, and I need to take 2 holidays now from my work where I cannot support my family. What are you going to explain?
Again, I apologize, and I will explain that is from the legal aspect. I can't process. I can't take a decision on behalf of you or best of interest of you while you are sleeping, and you have full capacity to decide. So I will not take that decision on behalf of you.
Fine. Good. Okay. So. Yes, Mohammed, basically you cannot do a procedure for a patient who had a capacity and who has not consented for the same. You are not doing it. And the reason why you are not doing is The patient, even though the patient will be very unhappy, even if I am a patient, I would be very unhappy when you come and tell that, okay, the mistake has happened, so you need to go today home, let this wound recover, I will come back on another day. I would be very unhappy when I am a patient. However, as a surgeon, I would say we are not entitled to perform a procedure when we don't have a consent. We are not medico-legally or ethically allowed to do a procedure for which you have not consented, and this is the rules. Yes, we completely understand, and I completely agree that it is a very difficult situation for you, and we would take necessary steps, and I would take up the accountability for this. I will do the assessment of what mistake has happened. We will revert back to you, and any kind of support which you would need, we are happy to provide within our limits, and this is why. So this is how you need to approach. Okay.
Okay.
Yeah. So here, yes, Prasad, tell me. Prasad? Unmute yourself, Prasad. You were muted. Okay, I think Prasad.
Can you hear me?
Yes, Prasad, tell me.
Yeah. In this scenario, I would do 2-3 more things. First of all, if I'm a day one consultant or in a new trust, and this is the first operation, then probably I would not do the further operations, the next line of operations on that day. I would speak
You will
with maybe
cancel
my
all the
colleague.
cases?
No, I would speak with my colleague and the clinical lead as well, and I will tell them that this is the scenario, and probably if someone can take over the further list, then that would be better. Secondly, I will during the debriefing, I will speak with the whole team and tell them that this has happened, and this is basically system failure starting from the WHO checklist. And third thing, after that, I will speak with my registrar as well individually. And plus, the last thing, I think I will definitely write everything on my notes, duty of candor, then letter to the patient, and plus this patient should be discussed in the M&M meeting.
Excellent. Good. Very good. Yes. So these are certain things. So just to make even more polished, let me tell you the background, and then I will tell you, if I am you, how I would have answered. So in this exam, you will definitely have 2 or 3 scenarios where the ethical component comes into picture. Okay. So it could be a whole ethical scenario like this, or it could be a part of a mistake which is happening through other assessment case, other cases like whatever cases you have been doing. And you will be having questions on clinical audit. You will be having questions on clinical governance. You will be having questions on never event, missed event, no costs, what's the other one? The M&M and stuff, all the medical legal aspects. So you need to know the basics of how you address certain things, which again, it comes by the practice, by knowing more and more. So the key things here are knowing the basic medical ethics and medical legal aspects, which we are expected to be aware of as a day one consultant. Being accountable, okay, is very, very important. You take up the whole responsibility. You come into the picture without hiding. So when I ask you a question, so how do you do as a day one consultant, this has happened, what you will do to gain back the confidence from the rest of the team is, you will, in the next departmental meeting, I will volunteer myself, or in the next M&M, I will volunteer myself explaining what has happened. Okay, this has happened in the case, and I would voluntarily put forth the learnings from this mistake. Okay, and what all steps you have taken. So I am taking the responsibility for this. I have initiated a root cause analysis for this. I have initiated a datex for this, which we are evaluating, and I had personally spoken to the registrar who has done this. However, things could have been avoided, or I should have been little more. You should not tell that. No, I will, from next time onwards, I will go and consult the patient. That's not the role for a consultant. Of course, the registrar has to consult. You cannot, just because there is a case which has happened, you cannot straight away tell that from now on, I will do the consent for all the patient. No. So you will tell that the next step which I'm going to take means, of course, apart from this, I had made sure that I have given 2 clinic appointments in the ambulatory clinic here, and I'm making sure that the patient is being safe. Okay, and I've also given him the expedited date for the other operation, which is going to happen, and I will make sure I personally will do this operation by myself. Okay, and I have also ensured my registrar and my team to do the clinical data course. So there will be always some course on patient safety. So I had personally done this patient safety course in the mandatory training, and I have also instructed to make sure for them to brush up the patient safety course, whichever is in the mandatory training, to prevent these mistakes. So this is how you need to gain the confidence. And of course, in the next few lists, I will make sure that this is all looked after properly before I move forward. So key principles are: when the patients have not consented for a particular procedure, you are not doing. Your primary aim in that situation is patient safety. So if I am in that situation, when I gone in, I would tell that, oh, I am concerned about the situation, I will stop the procedure. I'll speak to the anesthetist to tell that the patient is safe. Then I will go back to the clinic letter and I will make sure whether the clinic letter is wrong or the consenting is wrong. If the clinic letter is confident enough to telling that it's a right inguinal hernia and it is what is explained, then I will come and check, ask the registrar what made him mark on the left side, and if he really examined the patient. If he had really examined the patient, and if it is on the left side which he has found, and if he has consented for the left hernia, and if there is a hernia there, I would operate. However, if there is a mistake where the registrar has told I have not examined properly, then I would stop. I will scrub in. I will close the left groin region. I will not operate on the right side. And the patient goes to the IT and wait for the patient to be awake. And as Prasad told me that because this is the first case, and this is the first case I wouldn't be very comfortable continuing my list. So I will quickly speak to my colleague who can come and take over the list. If in case there is no one to take over the list, unfortunately, you will tell that you will continue with the list. Okay, as long as you feel safe to proceed. Okay, again, in the exam, if you say that I am not feeling safe to proceed, they might consider you as a weak person to be a consultant. So you will tell that then that's a difficult situation. You should reason in a way that I don't want the other patient to suffer, but I will be a little more cautious. I will make sure the consenting is done. I will make sure when the patient comes in, the sign-in process is done properly or not. So one more thing which had failed here, whom to be blamed when I asked, to some extent, the patient is also responsible here. How, in the sense, is as long as they have done the signing in of the WHO checklist properly, where the patient is questioned which side you have hernia, if he had told on the left side, then it's a mistake of the patient also. Or if the sign-in hasn't happened, that question has happened, never happened, then it's a very serious incident which has happened, which you need to pick up. And in the debrief, you should have everyone explaining what has gone wrong. You would tell that you will speak to the registrar individually, and you will put a date text by yourself, okay? And you will initiate. So certain terminologies are very important. The root cause analysis, you will do it. Date text, duty of candor, documentation, patient safety, these courses, whatever are the courses. So these are the things which should come here. Well, so they will ask in the exam, in this situation, they will tell that, okay, I am the patient, you explain me the mistake, they will tell. And exactly like how I told, the examiner will answer you, and they will see how you manage these things, okay? Ultimately, patient should be safe here. Okay, and you need to be safe as well. You need to continue your career next, rather than you being penalized straight away. Okay, Mohammed, you have any questions?
Sorry, if it's this similar scenario, my registrar in emergency consented patient for pilonidal abscess. I'm going to theater. I find it perianal abscess. Do I proceed in the same settings, stop the operation, wake up the patient, or because it's very close, anatomy is very close and mistake can happen here, what I should do?
It's a fantastic question, actually. So, yeah, so pilonidal abscess and perianal abscess. Yeah, I mean, you can explain in a see. In my view, pilonidal abscess is a different disease, and perianal abscess is a completely different disease. And that's an emergency situation. However, yeah, that's an emergency situation. However, you would not be penalized if you drain it. Okay, but if you think that that's not an emergency situation, if you think that it's not an emergency situation and this patient has been consented wrong, for example, you had consented wrong for a pilonidal abscess while he had a fistula in ano, where you think that you need to leave a ceton or a fistulotomy, okay, and if you think that it is not an emergency, you would,
it is abscess. The patient is not.
if it is
the patient
abscess,
is not septic. This is the borderline patient. Patient
yes,
is not septic. He's not dying, but this is
yeah,
an abscess. So
in that case, you can act on the best interest of the patient. Similarly, for example, all our appendicectomy patients, okay, you do go in for, you book for the patient as laparoscopic appendicectomy, okay, plus minus conversion to open is what you have written. You gone in and you find that there is a big ileocecal mass, you are a colorectal surgeon, and you give him an end ileostomy when you had not consented this patient for stoma. That is done. That is fine, because that is an emergency situation, and you are doing whatever is the best for the patient. That you can do.
thank you.
But not in elective situation.
Thank you.
Yeah, Shaza, can you unmute yourself, Shaza? Yes.
Yeah, hi, good evening. I just wanted to ask Manny, when you're put in scenarios when you normally wouldn't put yourself in that situation, for example, as a first day consultant, and this is your first list, I would assume, me as a consultant, I would not sort of take it for granted that my registrar knows how to consent, or because even during my training, my bosses would obviously see how I am first, get a flavor of who I am before letting me consent independently or do an operation independently. Would you make comments like such as, for example, me as a registrar?
You can tell that.
Yeah, from my practice, even with my juniors, before letting them see patients or consent patients or doing anything in theater, I would have to like get used to them and see how much they know and how can you make comments like that before answering, or is that unnecessary?
So in this situation, you would tell that as a day one consultant, I wouldn't have done this, because as a day one consultant, I would be a bit more careful, and I would have obviously gone myself. And in my view, this shouldn't have happened. This is how you can start this. However, the examiner will tell you that no, that registrar is a very senior registrar whom you had worked with for the last 5 years, and you felt very confident, so you allowed him to take a consent. Now, this is how they will answer. But you can tell. Again, so each scenario, when the question is asked, majority of the time, you will know what is the crux of the scenario and what they are expecting you to discuss for the assessment. Okay, so you need to be smart enough to quickly jump into the area where they are going to assess, rather than wasting time in the introduction and conclusion and giving long sentences. Okay, yeah, you will obviously know that you will tell this, but you will obviously know that the examiner is going to tell no. This is the same scenario, like, you know, I will ask for a vascular consultant help, I will ask for a HPB consultant help, but you would obviously know that the examiner is going to tell there's no HPB surgeon, there's no vascular consultant. So you should you need to tell, but it should be quick and jump into the area where they want you to discuss.
Sure.
Yeah.
Lovely. Thank you so much.
Good. Right. So what I'm going to do now is I'm just going to stop the discussion. Yes, Shaza, is it mistake or another question? Okay, fine. So I'm going to stop sharing. I'm going to take last 10 minutes quickly to explain about the course which is about to start, because I know majority of you had joined the course, and few of you might be thinking of making decisions. So just give me 5 minutes to finish my what we are going to do in this course. So let me bring it here and share screen. Right. Right. So about this 9th edition of the course, most of you would know, but if people who are not aware, so this is the 9th course which you are starting, accredited by the Royal College of Surgeons of Edinburgh. It starts on Feb 23 and it goes until May 11th, mainly focusing for the candidates giving exams in May and September 2025, as well as the international candidates who are going to give their exams in November. Okay, so this course is complete. You might by this time be aware of different courses, standard courses for the FRCS exams. I don't want to name, but I would like to say how our course is different when compared to the other course. So it's more than a course. So we never call it, although we named it as a course, it is more of a mentorship program rather than a course. So in the standard courses, what happens is the course runs for 7 days or 5 days or 4 days, where you go in, they'll be questioning you like exactly what I did. Fix a time, 8 minutes you discuss, 2 minutes feedback, next candidate, 2 minutes feedback, and go. It's exactly like a quick mock exam kind of course rather than a mentorship program where we discuss in detail about what is expected in this exam, what is looked after. And it is a slow and steady process of learning over a period of 3 months rather than bombarding you from 8 to 10 for 5 days continuously. So that's why we call it as a mentorship program, where if you see our schedule, there is a gradual and systematic introduction of topics. We go from easy topics to the hard topics. We identify, we develop a good faculty candidate relationship, identify the weakness of individual candidate, strengths of that individual candidate. We advise them what to do, and this is how we build them for the exam. So we are a group of close to 35 faculty members. Most of them, I would say 80% of them are consultants and 20% of them are senior registrars who take classes. And again, this is all curtailed for the needs of the candidates rather than assuming everyone as a single batch and we teach. So again, when I say curtailed to the needs of the candidates, when I say the specialty candidates are taken separately for their specialty rather than teaching the breast for whole flock, which happens in most of the other courses. We don't, although we have rapid review revision lectures, this is not lectures like any other courses. Here, what we do is there's a 3 hours kind of a discussion we have. So if it's a HPB, benign biliary disorders as a topic, then we will be discussing for 3 hours, exactly like I will put this scenario. We will be discussing and we will be moving on. This is how the lectures are. And in the weekend, exactly like what we did here, the entire batch will be divided into 3 groups, not more than 7 to 8 candidates in a group. And every Saturday and Sunday you meet, each candidate will be answering 2 waivers along with the detailed feedback, again, as well as what is expected in this particular question and things. And what we do is we learn by doing rather than imparting these guidelines and stuff. And as I told, if you have spoken to colleagues who have given this exam before, we pick up candidates, we tell them that you are very weak, we will tell them that you should not write the exams, and we tell them that you might need some additional sessions. Sometimes if the whole group, say an upper GI specialty group as a whole is weak and stuff, then we might have additional sessions on the top of whatever we do. Okay, so this is how we do it. So in other words, basically, we are not very, very strict about our schedule. We are very flexible depending upon the need of a whole team and the need of the individual. And all the 35 faculty are available in a Telegram group, which I will come to you quickly, where any kind of questions, any kind of doubts you have, we will be addressing. So the teaching or the mentorship happens in 3 different ways. One is the Viva itself, where you come on the weekend, where you discuss. That I would say 60% of the knowledge is through the Viva discussion. The rest, I would say 30 to 35% under overlapping knowledge on the Viva will be on the lectures. Okay, each lecture is like 3 to 3.5 hours. We have 17 lectures over a period of 3 months where we'll be discussing. And all the important facts, small concepts will all be discussed in the Telegram group, which again continuously happens for 3 months' time. You will be interacting with your candidates, colleagues, and we will be putting questions. Lots of images will be discussed here and things like that. Okay, and of course, the other important plus point is all the sessions will be recorded and it will be available in your mobile devices and your desktop within 24 hours, and you will have access until the entire 3-month period of this course until the day of your May exams, or if you're means for the 3 months you will have. What not to expect is, again, people think that, okay, this is an extensive course where we teach more than 300 plus hours, and they think that, okay, we will just participate in the sessions and we will be enough, we can participate. No. So this exam, there is no limit of a knowledge, actually, to be honest. If you prepare for 2 years, you will be continuously preparing. There is no limit of what you need to know, what you don't need to know. More and more you know, better is the outcome. Whatever essential you need to know, you should know. Whatever additional you need to know, try whatever you can. That's all. So we will not be spoon feeding the knowledge itself. Our crux here is telling you the essential components which is required for the exam, essential Viva techniques. We'll be correcting your entire how you speak, how your body language should be, how you need to do this. We will do a mock exam. We will definitely give a very clear insight on you, which you can realize by yourself to tell whether you are ready for the exam or not. Okay, and we will never give false reassurance. So as I told, every course, 2 weeks or 3 weeks prior, I had personally called the candidates and I have told, please quit the exam. You should not write the exam. I will tell. Similarly, my colleagues, other senior faculty in the group, if it's their specialty, they personally speak to the candidate and tell, if we think that you are not prepared, you are not prepared. Similarly, all the Vivas which happens, the feedback will be very blunt. We will tell exactly how bad you did or how good you did. It's mainly because at the end of the day, we need you to be successful and you need to be successful as well. You need to understand what mistake you are doing. So that's what we do. And not to expect is we will cover everything. So how much ever you prepare, as I told, if you're a well-prepared candidate, there is a 10% chance that there is a 10% of the questions in the exam you will not know, or you might be hearing for the first time. Okay, and to get the most out of it, sincere commitment. Okay, you need to participate. Yes, the schedule is extensive. Okay, extensive, but you will know what you achieved out of it when you gave the exams and came out. So I had candidates, so the last 3 days was the exam. I had candidates telling us that, okay, they all felt very comfortable and confident. What we want is, on the day of the exam, you should walk in confidently and you should feel that this exam day is any other Saturday or Sunday which you have been practicing in the last 3 months. That is the feel which we want to give you. Again, the most common cause of failure in the exam is thought blocks and stress on the day of the exam. You go unprepared and you feel very anxious and your brain doesn't work because it's a 5-minute scenario. It runs so fast. Okay, and that doesn't come straight away by registering for the course or listening to the videos, but you need to participate. You need to actively volunteer. You need to keep aside everything. If you are preparing for 3 months, you keep aside all your relaxation, you keep aside all your locums. You should make sure that this is the time you are going to allocate. You invest all your money, whatever you need, attend the courses, attend the conferences, do everything, invest all your time in this, and 3 months later, you close all your books and relax and enjoy. The worst feeling is you prepare something incompletely, underestimating this exam, and you fail in the exam, and then you realize that, oh, we should have done this, we should have done that. By this time, you would have taken a lot of leaves before this exam, then you wouldn't be able to compensate that, then those things come. So if you have decided to take the exam, 3 months, don't think about anything. And I assure you that that's very, very essential. If someone says that this amount of preparation is not needed, then either they are very lucky or they are super intelligent. I'm talking about an average candidate. Okay, and active and interactive participation from day one, sincere effort, very disciplined preparation. And as I told, we have the Telegram chat group, which will come in a minute. And you should form study groups. Again, that's very important. In the weekend, when you come, you prepare and come for that particular topic where faculty will guide you. But the rest of the days, you should start forming the groups straight away, 3 or 4 people in different specialty. Every day evening, 9 to 10 or 8 to 9, you all come on an online meeting. You ask question to the other person asks. And like how I critically appraise, by 2 or 3 weeks attending the course, you will know what is expected and you will be able to critique the other person answering. This is how you learn and go to the exam. And as I told, speak to your mentors on your needs. Okay, speak to us if you're in the part of group. Most importantly, speak to people who has already given this exams, or who has, if at all, if you're looking to participate in this course, speak to candidates who had already participated in this course, what helped them to get the maximum out of it. Yeah, all the courses in this country are costly. It's not that it's we take so much of money. The running these courses are extremely costly. At this, what we want is, I know that I personally feel that it's a very costly fee for any course in the UK. But what you need to know is, at the end of the day, you should be selfish, making sure that you get more than what you had paid for. And this is in your hands to get out of it. Okay. And as I told, because we give the videos here, you will be able to see how you answered. Okay. And we never conduct waivers behind the screens. We won't question you unless you open your camera, because we want to see you, how you sit, how you answer, how is your eye-to-eye contact, etc., etc. And you will see, based on your own recordings, how you improved over a period of time and how you prepared for the exam. Okay. And as I told, we'll give blunt feedback. We'll grade the candidates. You will be having extensive Viva training, which I can assure you. Small groups. As I told, one-to-one mentorship if we really think that if there is someone very weak. Most importantly, we will tell you how to approach different scenarios, how to approach a 5-minute scenario, how to approach your specialty scenario, and a clinical examination scenario. Other important thing, which is a highlight of our course, is the mock exam at the end. So the last 3 or 4 days of our course, means last 2 weekends, is just mock exam, which will exactly like your actual exam. The exam starts at 8 in the morning, finishes at 10 in the night. You come exactly at your time interval, exactly like your exam, and you will be having a one-to-one examination. And we provide mark sheets exactly like how it is happening in the actual exam. Okay, that gives you the actual feel before you go to the real exam, how it is. And it usually happens 2 to 3 weeks prior to your actual exam, and you will be prepared for that. Okay, and of course, we are all easily available. So this is the assessment sheet. This is taken from our 7th course. So every Viva you answer in this course, starting from day 1 of the course, you will be marked like this. If they'll choose the faculty, you will choose your name. We will assess you based on your overall performance, your overall professional capability, and these things. Whatever we saw in the initial marking descriptor, we will mark you like this, and we will write the comments. Okay. So in the out of 3 months of course, at the end of the first month, you will get a report like this. Okay. So these are the various dates of the Vivas. So these were the faculty who did the thing, what was the session, and you have your rating on how you did, and we will write here. Okay, so what were the problems? No issues. You will get better with the course scores, performed very well in lab. So based on whatever you performed, we give a detailed feedback, and this also serves as an attendance report for you. As I told, the entire course is closely monitored by the Royal College of Surgeons of Edinburgh, and all your CPD points and stuff will be based on the attendance sheet we submit. And this is a proof of record for the attendance for you and for us. So in the 3-month course, the first month you'll get a report like this. The second month, again, you'll get another report. And then this is how the mock exam would be. The mock exam mark sheet will be exactly like this. So general surgery, these are the 4 mocks we will be conducting. And we will give you the marks like this, and we'll give you a feedback like this. Okay, this is how the mock test and the mark sheets are given. As I told, every hour of your participation in the course, you will be offered 1 CPD point. This will be the certificate we issue at the end of the course, which we can use for your appraisals and stuff. This will be the CPD certificate, which you give. If a candidate had fully participated in the course, they would earn close to 120 to 130 CPD points. Okay. And coming to the schedule, this is our schedule for this course, which is starting on 23rd of February. It starts with the orientation, and these are the days and times. Okay. And just one thing which I want to tell, because several colleagues of you and a few of you here has questioned us how it works on a specialty weekend. For example, on the general surgery and the critical care, which happens on Saturday and Sunday, it happens only at the evening. It starts at 6. It goes until 9:30 for sure. Majority of the time it will overrun. Okay, we will tell during the orientation of the course how things will overrun. Majority of the time it goes up to 10 o'clock. Okay, and because this is going to be 1 month of Ramadan fasting and things are there, we will break in between in the evening for your prayers and stuff. So this happens for the general surgery. And when it comes to the specialty weeks, what happens is on the mornings, Saturday morning and Sunday morning, the specialty, if it's upper GI weekend, the upper GI specialty candidates alone will come between 10 and 1 with an upper GI faculty, and they will discuss core upper GI specialty topics. In the evening, all the non-upper GI trainees will come and they will discuss scenarios which can come from upper GI surgery topic. So if you're a colorectal person, you will not be attending the morning session, but you come on the evening, but you will discuss only on upper GI scenarios on Saturday and upper GI scenarios on Sunday. Same thing happens on breast. For the breast, generally we have 3 specialty trainee scenarios actually for the breast alone specifically, mainly because there is a lot of areas to cover. And sometimes, you know, for example, in the previous course, we had an additional upper GI specialty trainee session. Sometimes we have colorectal and things, depending upon the need. But definitely for breast surgical trainees, there are 3 specialty trainee sessions, which means 9 hours of Viva will happen on your specialty alone. And then you have the academic paper statistics thing. Then last 4 days is the mock exam. So this is our Viva schedule, and this is our lecture schedule. Okay, this is how we have lectured. So the date we will be finalizing in the next 1 or 2 days, but the first week will be critical care and emergency. And again, although I had put it as a lecture, this is not a proper lecture, I would say. Most of these are again a 2-way discussion. Okay, so we will be putting slides. Few of my colleagues, they use whiteboard to teach. They will put up scenarios, common topics which are commonly questioned in the exams. The candidates will be pointed out and discussions will happen. So this is how we do this lectures. Again, although the lectures are marked, so this is minimum of 3 hours lecture. Most of it can go up to 3.5 to 4 hours sometimes, but the minimum is 3 hours time. Again, all these lectures will be recorded and it will be accessible for you. This is our results of our 7th course. So we are starting the 9th course. The 8th course just got over. Our candidates have appeared for the exam. The results will be out next Wednesday and we can share our results. However, this is our previous course result. If you see, this is the national average, cumulative average since 2009. You can see this in the JCIE website. For a UK trainee, the average pass percentage is 88 in our 7th course. When I say the total people who gave the exams were 32 candidates. So 97% was a UK trainee pass percentage and 86% was our non-UK trainee pass percentage, and the overall cumulative pass percentage of ours is 83 compared to 70 in the whole nation since 2009. And as I told, just a brief about the mock Viva. Each candidate will be having 40 minutes of one-to-one Viva in general surgery, 30 minutes trauma critical care, 30 minutes academic paper basic science, and 40 minutes in your specialty. So out of 6 Vivas which you actually face in the exam, we will run 4 of it as a mock. Okay, and this is how the mock schedule would appear like. Just I had put here to know, for you to know how much planning we do. So these are the 4 days of the mock exam, and there will be 3 rooms which run from morning 9:30 until night 9:40, and GS1, GS2 are all the candidates. This is exactly the schedule which you will get for your actual exams also. You will be having a date here and your name will be, you will be a GS18 candidate. So all the 18 at that particular time, you log in, you finish your Viva and you go. So this is how the mock exam is planned in our course. And this is the amount of hours spent just online in our 8th course, which just got finished on 19th of January. Okay, if you see the total number of time spent on general surgery Viva is 20 hours, critical care is 23 hours. When I say cumulative, we'll be having 3 groups running every day. Okay, Saturday there will be 3 groups, Sunday there will be 3 groups. but you would have participated only in 2 groups. Saturday, you would have been in one group. Sunday, you would have been in the another group. But the third group, you wouldn't have participated, but the recordings of that group will be available in your library, which you should watch. Okay, so this is how our teaching goes. Okay, so this is the cumulative hours spent on different specialities in the course which we finished, and this will be the amount of hours of recording which you will be having for a period of 3 months for you to revise. And as I told, we have the learning management system which is available for you to see these videos in your mobile as well as desktop. This is how the Telegram group appears. Okay, Telegram is not just like an open chat group. So we create a group like this, and we have subgroups within the group. Okay, so statistics, breast, everything will be there. In the general side, regular announcements will be there, and every individual topic, for example, if you're discussing a colorectal topic, it will be discussed in the colorectal. If you're discussing something in breast, it will be discussed there. So, and we have something called as a rapid revision area where we will be posting several things which you need to revise before the day of the surgery. For example, in the last course, if you see, the colorectal surgery alone had close to like 1,000 messages and stuff. Every day something will be discussed. Okay, so as I told, more and more information you know, better will be the outcome in the exams. So so how it works is, at the end of the exam, if you go to open breast surgery and you start the chat from the top to bottom, that's more than enough of revision of you know, the unfamiliar territories and stuff. Okay, but again, the Telegram group is something where you need to be constantly keeping track, or else if you don't open the Telegram group for 5 days and you come back, you will feel very overwhelmed with the number of messages in each group. I am not telling all these things and I'm trying to stress you up before your preparation, telling that you should not think that what I'm telling that, you know, I'm discouraging you or something. But this amount of hard work is needed for an average candidate. Okay, for any average candidate to clear this exam in their first attempt, or to appear for this exam confidently, we would do this. And we have been doing this for 4 years, and this formula has been excellently rewarding for both for us and as well as the candidates, and we follow the same. Okay, good. Right, I'm going to stop presenting here. If you have any questions, you can ask me, or we can wind off. Yes, Firas, tell me.
I have 2 questions.
Yes.
Question is that do you have in your library the resources that we can read from, like up to date? For example, we have today some discussion and argument about the medical legal aspect and the consenting and things.
Yes. So as I told, you know, if you might be wondering why we are having this, you know, the app, we are putting these contents in the app, and whoever has had, we have given the access to all the registered candidates to the initial learning materials. If you see, the app is super protected. Okay, you should not be screenshotting. If you screenshot, your access will go. You cannot download anything. The reason being, because it's all monitored by the Royal College and stuff, most of the articles, most of the things there we have purchased, and we have, or things which are freely available in the internet and stuff, which we have put there. Okay, most of the questions and most of the essential things will be there. Whatever we discussed today, assessing the capacity, etc., is all there in the group. Okay, but there are certain things which, if it is very costly, or if it is something which is copyright protected, will not be there. Again, the reason why we have kept the access to this learning materials this restricted is because we have got permission to use these for educational purposes and stuff, but not for circulation. That's the reason. But you will have most of this information there. But for example, say if you don't find something and if you have a query and stuff, you will put up in the Telegram group, straight away someone will come up with the resources and references for you. If not the direct paper, we will give you a link where you can read.
That's great.
So
That's helpful.
exactly. As I told, the key thing here is any doubt. For example, today you had a doubt. Okay, you had a patient in the ward where you don't know what are the principles of managing. You don't know what is maybe a package of care. For example, simple thing. Okay, we will give you a resource. If you put up there, someone of us or even your colleague will put up there. So that adds as a resource. So you don't need to worry about that.
A second question is that I am colorectal, but I'm just wondering for the upper GI trainee session in the morning one or HPB,
yes,
is it possible to join just as a just observer?
No. So as I told, because we want to keep it very focused for them, we generally don't entertain others and we keep it very closely restricted. However, even these sessions are recorded and it's available for you if you want to go through.
Okay, that's fine.
Yeah. Okay, but in the colorectal, if you see, you might be wondering why there is no morning sessions. For colorectal, we do it differently. So colorectal days, we separate the whole group. There'll be 4 colorectal groups and 1 non-colorectal group. Okay, so each colorectal group will have only 5 candidates, and each of this group will go into 4 sectors. Okay, there will be a cancer sector, there will be an IBD sector, there will be an benign and pelvic floor, as well as something else I forgot actually. So so that is how it is covered. So, but you don't worry, we will discuss all these things when we start the course. And as I told, any kind of feedbacks and inputs, we are quite very flexible. If you speak to your colleagues who were in our course before, they would tell us how we adjusted and things based on the needs. Yeah, so you don't need to worry much.
Thank you.
Good. Any other questions from others? I have Mina Girgis here. He's the Associate Course Director. Mina, would you like to add any words if you're around?
Hello, can you hear me?
Yes, Mina. Yes.
Hi, Manny. You have been very thorough as always, as usual. I think it's a bit overwhelming. We always get few questions in this first in this stage. First, is 3 months enough to prepare? The answer is yes, if you start now. I'll just add a few things. It's the FRCS exam is an exam which is very easy to fail and very easy to pass as well. The good thing about the course that it gets your ducks line for you. It gets everything. You have done your own calendar for studying. You know that this week you're going to do general, next week you're going to do colorectal, and the way it is designed to have lectures during the week when you would be just a passive learner, right? Just making sure that you are grasping all the information, all the knowledge that you need to, and then practice over the weekend. Even if you are on your own, I think it has done all the work for you. The thing that you need to do as a candidate is, once we start the course, you should start studying seriously. As I always say, studying for FRCS is not something that you do in your spare time. It's something that you should spare time to do. It's not after you finish your clinic and your theater list, and then you had your dinner, and then you had some time with the family, you got 1 hour before you sleep to study. It wouldn't work like that. So you have to spare at least, I would say, an hour every day, go through things. My advice is incorporate that as part of your day in work. So if you finish work, for example, at 5 p.m. or 6 p.m., don't go home straight away. Spend an extra hour in the library when it's all quiet, and then go through things, preparing for things. If you do that, you'll find it very easy. The other thing that it's the commonest cause for failure in the FRCS exam is it's not the lack of knowledge, actually. It's poor presentation, which is something you cannot be taught, but you have to practice. And that's why we insist. We understand that sometimes uncomfortable for some candidates, but we insist that you engage. We insist that you open the camera, because that's how we assess you. I remember a candidate that he was one probably 2 or 3 courses ago, and it was his last attempt for the second part of the FRCS. Otherwise, well, he has used all his attempts already. The only when we have spent time with him, we realized that his problem is actually his body language, his eye contact. Well, he fails to give the impression to the examiner that he is a consultant, and that's something we would like to help you to know. We would like to help you to address, but unless you help us to help you, we'll not be able to do that. That's one thing. The other thing, comment on Farah's question about. And that's something we get all the time. Can we attend the specialty lecture? It's not that we are hiding this extra information from you. They are readily available for you on the LMS. They record if you go through them again. But I think, especially when it comes to things like breast or things like upper GI, it's important to know what you need to know. Okay, it's easy to get more knowledge. There is no cap for the knowledge that you need to know, right? But I think the most important thing, and that's the most common question I get asked to about breast, is how much do we need to know about breast? Because if you dive deep into breast, and breast trainees will know that they will need to over everything about trials and, well, CD4/6K and all this chemotherapy and the recurrences and stuff. Is that really ST4 knowledge that you need to know? Probably not. So the main reason we do not want you to go to these specialty lectures is it's mainly we want you to be focused on what you need to know. If you want to know more, well, they are readily available for you. You can access them. But it's that, well, you would be wasting your time unless you really would like to know everything, which is fine. But I think you should know what you need to know first, then go the extra mile and go for what you want to know. Yeah, that's it.
Thank you, Mina. I think next week you will have a full evening because not everyone here are our course participants, and I think there may be, so next week again there may be a different group, so you can lead the next week. Yeah,
of course.
Thank you, Mina. Thank you. And for few of you here, I think you had contacted us and about this. So we still have maybe 5 or 6 participant spots left. So we are restricted to not have more than a certain number of participants. So if you're keen to register, please register. If you have any queries about the course, or if you want to need more information, please do contact us, and we are very happy to help you. Okay. Right. Any other questions from others, guys? Any questions? Anyone? No? Right. Good. I hope you had some understanding about this exam, some understanding about what direction you need to travel for this particular exam. If you have no further questions, probably we will wind off. This session will be recorded. Someone has maleficent. Okay, fine. So we will. So you can just go through. You can go to PrepMedico.com. Okay, that's the website. I can put up in the chat group here. PrepMedico.com. You go into this, you will have all the details. If you have any problems, the website also has a WhatsApp link to straightaway press, and you can contact to us if you have any problems. Every other details are there in the course. Okay. Fine. So, and others, again, next week we have a similar kind of a session. Next week we wouldn't be wasting much time, because this is the first session. I was going through the various details about the exam. Next week will be core clinical scenarios. We'll try to discuss maybe 7 to 10 scenarios, and Mr. Givkis will be there for the next scenario. Okay. Right. Have a good evening, guys, and thank you very much for attending today's session, and all the best and good night. Bye.
Thank you. Night.
Bye. Bye.